Why don't we have the committee members come up to the front, and we'll get started with the presentation this morning. This morning's session is going to be focusing on clinical space medicine, and should be an interesting opportunity to discuss some of the challenges that we face sending humans farther into space. This morning we're going to be doing this a little bit differently than we did yesterday. Yesterday we had a chance for each committee member to present for 5 or 10 minutes or so talking about one specific area, and then we held our questions till the end to create a dialogue with the committee members. This morning what we've decided to do is basically go through a series of topics, and I will be posing a number of questions of all of the committee members who will answer as they see most appropriate, and we would like anyone in the audience at any time to feel free to ask a question, interject, raise a comment or a concern. This morning's presentation is really designed to focus on the areas of space medicine that remain a challenge for us. We're not here to talk about all of the successes. We've had a chance to think about those in the past. We're here to talk about the challenges that we face in going forward, trying to send humans farther into space and keep them there working longer in space, and to be able to do that safely. So to start with, what I'd like to do is we'll go down the row of the panel members. We'll have each person give a brief introduction of where they're currently working and their interest of space medicine, and then we'll get started with the presentation. So we'll start off with Dr. Dave Wolf from Johnson Space Center.
Hello, hi, Dave Wolf, Chief of the EVA branch for the Astronaut Office.
Dr. Matviev.
Добрый день.
Good afternoon.
Значит,
Good morning.
в свое время я являлся российским врачом экипажей.
I used to be a Russian crew surgeon. I worked on Expedition 1, 4, 6, and 10, and partially Expedition 13. Currently, I'm working at Gagarin Training Center at the medical department, and I'm the deputy head of the medical division at GCTC. And what is of great interest of me is medical and biological training of the Russian crew members. Thank you.
Hi, I'm Rick Schuring, and I am the cross-integration lead for Constellation, along with my partner in crime, Dr. Jeff Jones over there. We kind of tag team all the Constellation issues for Moon Mars for MedOps.
I'm John Clark. I'm a former Navy and NASA flight surgeon now at National Space Biomedical Research Institute, helping with integrating research into ops.
I'm Smith Johnston. I've been at JSC as a flight surgeon since '94, and I've had the opportunity to work many shuttle missions, Neurolab, Hubble, Mir, and ISS docking missions, and just recently completed Expedition 16 with Dr. Whitson, which was a very interesting and very fulfilling part of my career here. My interests are the care and feeding and taking care of the astronauts, not just for the short term and their families, but also for the missions and also for the long term, for the rest of their careers and the rest of their lives, which I'd like to emphasize. My other interests have been the medical standards. Since '95, I've been the chief of developing the standards and working with our international partners to develop our international standards. And that's it.
Good morning. My name is Volker Damann. I'm a flight surgeon since '89 with the German Space Agency, and then moved to ESA in '95, where I took over the leading function in medical operations. My prime interests currently are, you always have to look forward for the next 5 or 10 years, is moving towards a new generation of flight surgeons, what we need to do to prepare next generations of flight surgeons to support long-duration explorative missions. How do we train them? How do we recruit them? What tools are we providing them on their way, hopefully, to Mars and to the Moon? Thank you.
Good morning. My name is Jean-Marc Comtois. I've been a flight surgeon since 1986, initially in the Canadian Forces, and then since 2000 at the Canadian Space Agency. My current position is the Director of Operational Space Medicine.
I'm too short. Good morning, I'm Chiaki Mukai from Japanese Space Agency. And I'm also the Japanese astronaut, 2 shuttle flyers, and also I'm very much interested in the science operation. So I backed up 2 Space Lab missions, and my last assignment from NASA was a deputy mission scientist for STS-107 Columbia. And then the current position of mine is the head of the JAXA Biomedical Research Office. Thanks.
Hi, good morning. I'm Jeff Sutton, and I'm the director of NSBRI. And at NSBRI, we believe very strongly in fostering the integration between the research community and the space medicine operational community. We also very much value and work hard at international cooperation and collaboration, and look forward to this interesting panel discussion.
And Judy, maybe we can get you to come up, and I don't know if whoever has those portable mics, if we could have one brought to Judy and Jeff, so that'd be great.
I'm Judy Hayes, and I'm trained as an exercise physiologist. My current position is as a deputy division chief for the Human Adaptation and Countermeasures Division, and of course my interest is in optimizing countermeasures, especially exercise countermeasures, for long-duration space flight and lunar and Mars missions.
Well, thanks very much, everyone. I think we have a fantastic panel. For those of you who know me, you'll know that I have recently left the space program. I now have the title of former astronaut or retired astronaut, and I must admit I'm having a little bit of difficulty with the use of the word former and retired, so I'll let you know when I get over that. Right now I'm a professor of surgery at McMaster University, and my job there is as director of a Center for Medical Robotics, developing surgical robots to help clinicians perform more precise surgical procedures in operating rooms, and also doing surgery, remote surgery at a distance. I think today's panel is very well suited to address the fundamental issues of human spaceflight. To start, I would like to tell you a story about my second spacewalk. Standing in an APFR on the end of the space station robotic arm, as we were moving towards the payload bay to get the gyroscope out of the payload bay, take it up to the station, I was standing on the arm looking at the Earth 440 kilometers below me, traveling at 10 kilometers a second. And I look over my shoulder out into space, this black, infinite, inky void. And you look at how extreme and harsh that looks, and you turn back and you look at the planet. And I couldn't help but reflect the fact that the history of the human species, everything that has ever happened, had taken place on the planet below me. And it was a very, very humbling experience to be able to look at the Earth, look back over your shoulder and think, this is where we are today. This is where we live. This is where everything that's happened to all of us has taken place. And then to look out into this infinite black, hostile void of space and say, this is where we are going. Absolutely profound. And you can have these insights in space in literally nanoseconds. It's quite amazing. And then, time to get back to work, go get the gyroscope and stick it on the space station. But truly the future of space exploration is for humans to leave low Earth orbit, to go back to the moon and go on to Mars. We focus very much on developing the engineering capability to take humans back to the moon and on to Mars. We debate and we talk about spacecraft design. We talk about how to best optimize human factors and human performance working in spacesuits and rovers. How often do we talk about the clinical capability, the medical capability of keeping humans healthy and safe working in these environments? We need to integrate this capability as we go forward in exploring space. And in today's session, we're going to touch on a number of the key factors that are very much involved in delivering healthcare in these extreme, harsh environments. And I guess we could probably start by asking the fundamental question, what is space medicine? And we all have a number of opinions on what space medicine really is. And my definition of space medicine is the delivery of healthcare in partial and microgravitational environments, whether it's in low Earth orbit, on the surface of the moon, in zero-G in a spacecraft on the way to Mars, or on the surface of Mars. We need to extend our capability to deliver healthcare. For the panel, the first question we're going to challenge ourselves with answering is who is best suited to deliver that health care. Today's model, we have crew medical officers who are essentially non-physicians. They're individuals that come from a wide range of backgrounds, astronauts that are given supplemental training to be able to function, deliver health care both on the space shuttle and the space station. We have cosmonauts who are given similar training. We have physician cosmonauts. We have physician astronauts. As we go forward, send humans back to the moon, and we anticipate having humans living on the surface of the moon for a long period of time, who should be delivering that care? What is the best skill set that we need? What about missions to Mars? And I'd like to open it up to the panel now to get some comments as to where they perceive the role that physicians may play. Should we have physicians on the ground? Should we have physicians in space? Should we have physicians working with non-healthcare professionals? What's the best approach? Rick, you look like you're ready to...
Well, I'm just thinking of something that Richard Jennings had said a while back about in the debate of who should be the, what type of physician should be going to Moon and Mars, whether a family doc, a surgeon, ER doc, or whatever. He said it's whoever you're looking at in the mirror that morning. I could make a compassionate argument for why it should be a family doc who's practiced in rural medicine and done just about everything that you've seen, simple to very, with some limitations, complex. But also the surgeons could make arguments for it's being a surgeon, et cetera, et cetera. So I think when you look at the evidence for what we've seen in flight, which is one of our main projects that we're working on, and the really limited amount of bad things that have happened, I think just a doc with real good, probably emergency medicine combined with surgical training, depending on what capabilities you think you're going to use, would probably fit that bill as far as longer duration missions. But I think the evidence suggests that you don't need tremendous medical skill capability because we just haven't seen things requiring that in spaceflight.
Dave, what do you think as a physician astronaut?
Well, I know I've been the crew medical officer 3 times, one long duration, and I know that you need help from the ground. Whoever you send in space, that's going to be critical, and that kind of telemedicine. So all the things going on there are powerful. We have the classic pyramid. In order to take care of those fewer and fewer, more severe conditions takes exponentially more input and effort and upkeep. So you have that classic difficulty. So I think a physician who is, or non-physician, adequately trained with some surgical experience so they can take instruction, and if it really comes down to it and you have to start cutting and going in for some reason, they can at least do it with some assistance through the telesystem.
Vladimir, I was wondering if you could give us a perspective on this.
Я бы хотел, в принципе, определить так, что на Луну полетит
In principle, I would define it in such a way as there will be a cosmonaut or an astronaut going to the moon. So the main purpose of the mission is that, but within that team, within the crew that are going to be traveling there, it's not entirely necessary to have a full-fledged physician, but I think that there should be 2 specialists who have been trained additionally and who have certain skills and medical knowledge and practical skills to provide first aid is what those 2 CMOs should also have.
Spasiba. Czech is one of the physician astronauts that's flown in space. I was wondering if you had a perspective on this.
Well, of course, if we have the medical background crew on board, it's much better. But since the number of the people on board going to the moon or Mars will be very limited, so it's very difficult. But I just would like to introduce my experience. I flew, as I mentioned, 2 times. The first time, I was the only medical doctor. Of course, we have the the crew medical officer. One other crew medical officer without having any medical background. And then one day I just realized if I have the heart attack or arrest and without having any consciousness, who will take care of me? I can take care of the other people on board. But if I have some problem, nobody, I think, will take care of me. And then I felt, oh my God, I should not have the cardiac arrest here. My second flight, we had the two crew officer. I mean, we had the two medical the MD on board. I'm the one, and also the Scott Parazensky, who is right now on the top, heading to the top of the Everest, were on board. I felt much comfortable on the flight. So psychologically, I think if we have very heavy the medical educational background equipped people on board, I think I felt much better.
Excellent. You know, I'm glad you brought up that issue. On STS-118, the two crew medical officers were myself and Barb Morgan. Barb is a fantastic astronaut. She's a great mission specialist. She had the basic shuttle crew medical officer training. Scott Kelly, our commander, used to say, well, on this flight, Dave is the crew's crew medical officer, and Barb is Dave's crew medical officer. So it's an interesting concept, and I would ask people in the audience if you have any opinions on this. Maybe Richard and Jay's out there somewhere. Any thoughts? Ellen? Anybody want to weigh in? Inessa?
I think that we already have examples of physicians being in space, and not just in physician, but physicians who were in space for a long time with long flight mission, and we have two of them. I wouldn't name the other, but we could compare and could make some conclusion what characteristic or what abilities should the flight physician for long term, for exploratory especially, flight have. This is a great example of Dr. Polyakov, I will tell you. Because he flew with 3 crews in a row, different crew. So he was very well trained as cosmonaut. In this, I agree completely with Dr. Matveev. This physician should be excellent cosmonaut, the first of all. He should be very communicative. He should know all the special features of cosmonaut, because they definitely have and genetically and by training developed special features. And of course, he should be educated medically very broadly. And if he possesses all the abilities of cosmonaut, he will be not afraid to be in acute situation, heart attack or surgery or whatever. And I know that Polyakov, who flew with 6 people, two in the row, by 14 months, he became extremely popular among our cosmonauts, and he deserved it. The other physician was flying also long duration flight, but he was not trained as a real cosmonaut before. And his success, in spite of the fact that by his education, by his specialization, he was much, much higher than Polyakov. He was heart surgeon, very qualified heart specialist, but he definitely had some difficulties in being the real member of the team.
Excellent. Thanks very much. Yes, go ahead.
Being a non-medical medical officer a couple of times, I was struck by what Christian reported. I think there are 2 areas that we look at when we consider risk: duration and severity of the environment. I personally was very surprised to hear Christian's report of the number of relatively serious medical cases he had treated. if we knew that we were going into an environment that we felt that Mars, for example, was going to be much more hostile than, say, the lunar surface when we went there, then I perhaps psychologically would want to have, at least a doctor on the crew. Whereas that's never been a big deal to me. In my experience, is only short duration shuttle. I think it's somebody mentioned the psychological factor, and I think we'll have to consider, do we want to think about the psychological factors of the crew when we make this decision on what's the makeup of a limited number of people.
Yeah, Charlie, I think that's an excellent point. Distance in this environment often translates to autonomy and the need for autonomy in delivering medical care. Jay?
The space medicine person is really the last line of defense. That the whole space medicine system is fundamentally a preventive system, and really the goal is to make sure that the crew medical officer is like the Maytag repairman. Because if things are like Charlie describes, you've obviously have a lot more problems operationally going on. Is that these operations are fundamentally not compatible with major medical problems. So that the focus always has to be to make sure that we're not sending the people who shouldn't be in space into space, that we're managing their physiology well, that we know how to deal with the kind of medical problems that come up. But these severe medical problems, the capability you need to deal with them is just so dramatic. Any one major medical event can just destroy a mission.
Yeah. So selection plays a critical role. Let's turn it over to the flight surgeons on the panel, and I'd like to.
Excuse me, Dave.
Sure.
Can I add a
Yes,
thought there?
Definitely.
Because we don't have food as good in space. We don't have entertainment as good in space. Nothing you have in space is really as good as sitting right down here. You ought to give some thought to the fact that you don't necessarily have to provide the Texas Medical Center level of care available in space. You're still on an exploration mission where a lot of other objectives really are prime over that. So be very careful you don't overdo the whole thing as well.
Excellent point. What I'd like the committee to address is if there's value in having physician astronauts in space, in your clinical opinion, without divulging any information that would be attributable, has the availability of a physician or cosmonaut, astronaut physician or cosmonaut physician, in any way been associated with mission success? Has it prevented a potentially unnecessary deorbit? Has there been a situation that arose on orbit where the flight surgeon felt comfortable taking care of the patient in space because there was a cosmonaut physician on board or an astronaut physician on board, compared to bringing the crew back and taking care of them on Earth? Smith?
Well, let's see. On Neurolab, I had 2 physicians, didn't I, in the audience? So it made my job a lot nicer. It was also the first time we flew a defibrillator. Mm-hmm. And as you recall, we actually did simulations of using a defibrillator. Hopefully, you're screening your people, so you don't have to worry about that. But of course, bad things can happen to good people. But yes, I felt much more at ease with you guys up there. You remember when we did the sims on the KC-135 that it was somewhat of a flail the first 1 or 2 times we did it. Then you guys got really, really good at it. So I think having a physician is a good thing. My points to the first question were, I think we have adequate training for shuttle. I think we have adequate training for ISS. It's about 72 hours with our CMOs. I think for the moon, we may have to consider it's again 6 months with a 3 to 4 day travel time difference. I think the thought of a cadre of astronaut medical corps folks that keep their medical training up, spend 3 to 4 months out of the year training specifically on medical care would be a good thing to do. This will be especially true for Mars. Mars is where you're going to have some sort of standalone care. And with the evolution of laparoscopic surgery, I think you're going to have that technique. You're going to have some surgical care capability. And so your CMO, when you're going to Mars, definitely should have some surgical training and background. And also you're going to need some more supplies, definitely. To answer your question, which I'm not sure if I did, yes, it does help to have a physician on board, for sure. Experience in anything, it helps when Dave has done so many spacewalks and you've done so many spacewalks when you're doing another spacewalk. I mean, experience is the name of the game. John, you got any thoughts on that?
Well, you're not going to like my answer. I agree with Dr. Matjev. I think you need redundancy, at least, for a complement of 6 to 8 people, you need at least 2 that are trained. I was a military flight surgeon who served in combat, and I'll take a SEAL independent duty corpsman or a special ops corpsman or a special ops medic anytime, because you need somebody. Remember, it's the team, it's the mission. So you need to have versatility. That means that you can't just say, I'm a doctor, that's not my job. You need to have somebody that can provide that level of redundancy if your primary guy gets injured. You've got to have a sustainability component to that, and that means decisions that are made that say, I cannot use all of the available resources to take care of this situation because now it puts the rest of the crew and the mission, but particularly the crew, at risk. And so you really almost have to have a kind of a military triage model which says, I've always got to balance the individual's right to care with the rest of the crew's right to sustain the mission. And it's a very different concept than I think we're trained in classic medicine. And so I'm probably an outlier here. Whether it's a physician or a non-physician, they need to have the skill sets and versatility to do as many different things as possible, and they need to be very adaptable. And unfortunately, as physicians, we work as a team with other medical folks, and so it's we got to avoid the situation where you say, well, where's the nurse, where's my IV, where's all my stuff? You've got to be able to, you're basically a one-man show or a one-person show. So I think it's got to be skill and competency based and how you fit into the general mission architecture and not just per se having been through medical school and residency.
And in-flight training and microgravities, very important.
And experience in austere environments to give you that sense of, how to balance the mission versus the individual.
Rick?
I think to answer your question, has a physician or would a physician in space potentially saved a mission or something along those lines? I can think of one instance where there was a physician, a crew member dislocated a finger. The presence of that physician was able to relocate that finger, splint it. Would a non-physician have been able to do that? Well, with help from the ground. I mean, relocating a joint is not that difficult a thing. Probably would have been able to do it. But getting back to something that Jay had mentioned, the other instances where we've had medical conditions occur and a physician's input may have helped were primarily related to poor screening at that time, where we've had dysrhythmias in the moon, et cetera, better screening techniques would take care of that. If that mission, let's say that 3-day mission had been over the course of a month, would that have been significant? Potentially. So that's where a physician could have helped. So to answer that question, there was something that we had experienced when we did our Haunt Mars project a couple of years ago I thought was worth mentioning. I was the flight surgeon as a crew member simulating a medical event where there was an incapacitated crew member, and we were relying on the ground for input, but one of the lessons that we learned, the flight surgeon in mission control said that it was disorientating for him because they're used to being relied on quite heavily to go through protocols and procedures, but when you had a physician there at the bedside, the reliance on the ground was minimal for using ultrasound, going through how to actually do an H&P, et cetera, et cetera. So I thought that was kind of eye-opening for us that the reliance on mission control, if you had loss of comm or there were other issues, was significantly reduced, which is not surprising, but that was certainly from an analog experience. And just to finish, one thing I thought was interesting was a comment that Gene Cern made when we met with the Apollo astronauts. He said, hell, if you could take a naval fighter pilot and train him to be a geologist, you could certainly take a flight surgeon and make him do something useful. So there's a whole cross-training issue. You're not going up there to support a medical mission. It's not about medicine. It's about the mission. And flight surgeons are pretty smart, folks. So we could probably do something else, not be the objective.
Yeah, Jeff.
Yeah, I had 2 comments. First was, I think that we have to start to think about missions to other planetary bodies is different from what we have in low Earth orbit. I think the challenges there are going to be you won't have instantaneous communication and consultation like we have on the ground. And there's been a lot of medical things that have happened and missions have been saved as a result of intervention that occurred as a result of interaction between the ground and the flight crew, so that the flight doc on the ground was able to give proper instructions, and those were executed in a way that allowed mission success. And we won't necessarily have that kind of capability for instantaneous communication when we have some of these missions. The missions that go to Mars, as an example, will need to have an autonomous medical care capability. So that's item one. Item two is, I think that there was a very good expert panel put together by Sam Poole before he retired to look at this issue of what kind of specialty care is really necessary for these long duration lunar and Mars missions. And the recommendation of that committee was that this is a unique trained specialty. This is not something that currently exists today in the training that programs provide in terrestrial medicine. This is going to be a unique combination of skills that will be required to do this mission properly. And I think we ought to take some lessons from that and not try to build a current terrestrial model and say, okay, we're just going to pluck this guy, whether it be an independent duty corpsman or an ER doc or whatever, and say now they're ready to go into space. It's going to require specialty training, as folks have already mentioned, in terms of extreme environment training, in terms of having skill sets that are going to be enabling for those missions. And I think we can borrow lessons from that panel.
Thanks. So we'll take two more questions, Nick and David.
First. This is the rule of the microphone. So I think this distinction people have made between acute and long-duration missions is the critical one. In acute, it's an operations decision on who should go. Long duration, there are significant advantages to having a dual-role physician, astronaut, physician, cosmonaut on board. And because you're looking at potentially not so much acute problems necessarily as growing problems associated with individual differences and vulnerabilities to the rate at which muscle's being lost or other kinds of space-related problems. And I could envision a physician on board being a significant both medical and psychological benefit to the crew, that there's someone who knows sort of what to do to try to mitigate it or to give additional treatment to somebody who is having a more difficult time in any medical area. So I think part of this, though, is the physician needs to be more than just a surgeon. They actually have to have the full role of what a physician is, the confidentiality, the understanding that people are not all identical, that you need to know what the strengths and weaknesses are of crew members from a medical perspective, and be able to deliver whatever's needed to keep the crew going long term. So I see, and if you look back in the history of expeditions, most had physicians on board. Now, Nansen, trapped in the ice of the North Pole for 2 years, his physician, Nansen wrote, had little to do because Nansen had so many countermeasures on board. He kept everybody pretty healthy, but it wasn't nothing to do. And minimally, the physician at least provided an additional kind of leadership role for managing your biological capability and your psychological health. So I think for lots of reasons, the long-duration mission, the mission to Mars, is where really this becomes a very important issue to resolve, and I would advocate for a physician, dual-role physician being on board.
Well, actually, I have a question, but I have a comment first, just echoing the other two speakers. It would be useful for me, for the panelists, I'm trying to get my head around the comments that some fit for orbit missions, some fit for Mars. And to me, the environments are so different that you might send a tech or two techs on orbit, but you might send a surgeon to Mars because of the time delays and autonomy, things we've talked about. So it'd be helpful for me if the panelists could address the kind of mission they're thinking about when they make a comment. My question is now, looking at Mars, a high autonomy, 44-minute round trip, time delay in communication, no sense of sending up some extra surgical gloves or bandages, to reach us. What is being done, or what do the panelists think ought to be done in preparation on a Mars mission for two specific medical emergencies? One is trauma, where you have to plan to do surgery in a low-gravity environment. The other are psychiatric emergencies where you might have to seclude, restrain, isolate a disturbed crew member. What kind of planning is being done? What kind of research can people like me think about that might help prepare for those two kinds of conditions on a trip to Mars?
Great question, and Rick, I think you've done a lot of work in this area. Perhaps you could answer it.
Well, right now in our MENOP CONOP for exploration, we have and gets into your first question for the panel, was level of care. And Mars is level of care 5, and within level of care 5, we have a fairly robust medical hardware, training capabilities, and I think there's an assumption, although there's not a requirement currently, that there would be a physician on board to take care of these. So the ability to take care of trauma is considered in there, although since we don't know what the mission, what the plan for Mars is right now, it's hard to really say what hazards we're dealing with and what risks we're trying to mitigate. So I can't give you an answer as far as how we'd actually handle individual trauma case, whatever. We would have the capability for advanced life support, for minor surgical, not major surgical capabilities, following ATLS guidelines, et cetera, et cetera. So that's the best I can answer on trauma. When we have a specific scenario that we're talking about and we understand what the hazards are and the risks, for example, one of the long duration moon considerations we have with moving heavy equipment is, injuries, crush injuries, compartment syndromes, things like that. So that's one scenario. But for Mars, we have no idea what we're going to be doing up there just yet. So I can't answer that more than that. Number two, as far as psychiatric issues, you bring up an interesting question, because I think Mars is going to pose significantly different psychological issues than even long moon will, just because of the remoteness from Earth. And tying in what David said about Nansen's work, as long as you provide a home-like environment as best you can, the psychological risks for catastrophic psychological problems is pretty minimal. I mean, Nansen, those guys were up there for almost 3 years and had no mutiny, had no problems, and he attributed to providing a home-like environment. Well, how are you going to do that on Mars? It's going to be kind of tough, but I think just your standard suite of psychiatric medications that we have, I think the BHP group has done a phenomenal job in terms of its one-on-one interaction and its countermeasures in terms of interacting with the crews, getting the families involved, et cetera, et cetera. But Mars is a different story. One thing that Apollo had said I thought was very interesting also is your psychological risks for Mars are not going to be in the first mission or the second mission or third mission, because they're going to be so ramped up for those missions, and it's all about the mission and the hubbub that'll be going with that. It's your third, fourth, fifth missions that you're going to have to worry about psychiatric problems and issues associated with that. So I don't know if I helped answer your question, Nick, but Mars, there's just too many unknowns to know right now, but it does fall within level of care 5. You can see we've actually published what that capability looks like and what medical hardwares and training fall under level of care 5, and might help answer that question a little bit better.
Excellent, thanks. Jean-Marc, you wanted to add a comment.
I'd like to go back a bit and address the issue who is best suited to be a crew medical officer. I think we've talked in terms of low Earth orbit versus exploration class mission, where distance was a key factor. But I don't think we can limit our thinking to distance. I think criticality of a mission becomes a very important issue. And if you're looking in the current program with the shuttle going to the ISS, each mission is becoming more complex, more difficult, and more critical, because a failure of each one of these missions could indeed jeopardize the ISS program. So I believe that a crew medical officer should have the skill set necessary to maximize our chance of mission success, be it a physician or a very well-trained crew medical officer. And do you feel more comfortable having a physician astronaut as a crew medical officer? Depending on the training, but certainly. But I think your level of confidence when they become your eyes and your ears goes up exponentially when you have a physician astronaut and that you speak the same language, and you have this level of confidence in assuring yourself that the diagnosis or the procedures that are being performed are probably more in line with what you think is being done. And I think this has an impact, not necessarily on canceling or an impact on changing the mission, but how the mission went along. I think your level of confidence, your ability to advise the flight director accordingly goes up when you have a physician astronaut or a very well-trained crew medical officer.
Thanks very much, Jean-Marc. I'd like to take us back to low Earth orbit and to consider the occurrence of a medical event on board the International Space Station and talk about what I might refer to as the chain and continuity of care in space medicine. It all starts with the crew member, the astronaut or the cosmonaut, and it starts with recognizing that something is wrong. I don't feel good. And then also being able to say to yourself, I need to talk to somebody about this. Because we all know that in terrestrial medicine, if you were to simply look at the incidence of heart attacks and symptom recognition, from the time of onset of symptoms in the lay population with a heart attack to the time that they make a decision to go seek medical care is a 6 to 7 hour window. You may ask yourself, what are they doing in those 6 to 7 hours? And people have actually done research and asked these patients, what were you doing? Some people are taking a shower because they want to be presentable to go see the doctor, and you kind of wonder, a little priority question there. So the whole issue about recognizing symptoms is very important. Do we train crew members to recognize symptoms? Yes. Mike Gernhard was a pioneer in saying, if we're going to go forward and implement pre-breath protocols for the space station, at the same time we need to be rigorous in teaching crew members to recognize the symptoms of decompression sickness. So on our cuff checklist for EVA, we actually have the symptoms of decompression sickness. Crew members are trained in recognition, and they're also emphasized to report these things early. So that's the first step in this cascade. Once something is reported, it presumably gets reported to the crew medical officer, and there's an initial diagnosis made. Generally speaking, if it's a non-medical crew medical officer, they're going to request a private medical conference. More time elapses while the PMC is set up. Flight surgeon's on the ground. The flight surgeon may ask more questions. Crew medical officer goes, asks the other crew member the questions, answers come back, and at some point in this exchange of information, a diagnosis is made. The diagnosis may or may not be correct, a tentative diagnosis, and they go forward with a treatment plan. And in making the diagnosis, we have very limited capability of doing a physical exam, very limited capability of doing ancillary diagnostic tests, but at some point the flight surgeon is going to say, this is what I think we're dealing with. I would like you to do the following. The next big question is whether or not implementing the treatment paradigm actually works. If it works, you can continue with the mission. If it doesn't work, or you have diagnostic uncertainty and the situation, the conditions in your list of differential are so critical, you may actually consider having to deorbit the crew, bringing the crew back. And in that situation, basically what we're going to have to do in docked ops is take the crew, put them either in the Soyuz or the shuttle, undock from the space station. Presumably, if it's during a docked ops phase and it's a shuttle crew that's docked to the station, we'll take the shuttle crew, undock with the shuttle, and leave crew members on board the space station. But if it's not during docked ops, we're contemplating abandoning the station for a medical issue. And that's a very profound decision with very, very significant consequences. So you're going to want to know with a high level of certainty that you're making the right decision. Once you undock from the station, you then go into a preparation phase, getting ready for deorbit. And there's very fundamental questions that get asked. And I'm going to focus on the shuttle scenario because I'm a shuttle-trained astronaut. I'm familiar with Soyuz, but I'm not Soyuz-trained. And in the shuttle, we're going to be taking care of the crew member on the middeck. The question is, where are we going to put them? Because if it's a station crew member and we've got 7 other shuttle crew members, we don't have a seat for an 8th person, so we're going to probably have them lying on the floor of the middeck. Will the individual bring an ACES suit for the ill crew member from the station? We probably don't even have an ACES suit for the ill crew member on the station. So the person will undoubtedly be unsuited. Will the crew medical officer choose to get suited in their ACES suit and try and administer health care while they're suited in a potentially pressurized suit? Will they put their gloves on? Will they put their helmet on? What are they going to do to continue to deliver health care on this individual? And then the next question is, what's going to happen to the individual physiologically when you expose them to the forces of reentry, which are quite different in the shuttle than they are in a ballistic capsule in the Soyuz? So ultimately you will end up landing. And your landing site will not have definitive medical care. Your landing site will probably have augmented medical care with paramedics. It could be a Black Hawk helicopter with military forces who are trained in delivering advanced medical care. And there will be presumably physicians there as well and flight surgeons and things. But they will have limitations because it's not a major hospital. So they will again diagnose, treat, stabilize, evacuate to a tertiary care facility. All of this takes time. That's the scenario that we're dealing with. What are the challenges that we have as crew medical officers, as flight surgeons supporting this? Stabilizing the patient, huge challenge. Limited consumables, the problems in transporting the patient. Time to landing, time to definitive care. These are all really big issues, and as Jay pointed out, we really hope we're never going to have to go there. We would prefer to screen out. So now my question to the committee is, when you look at selection standards, if you look at shuttle standards, we've evolved the shuttle standards to more mature, more rigorous standards for space station. The question then is, are the standards enough? Do we select and screen enough to prevent everything from occurring? What happens with the new knowledge that we have now? Yesterday we talked about potentially identifying genetic screening tests that could be used. Should these be used if we have the capability of performing these tests and identifying a potential risk for an individual of exposing them to radiation in space? Should these be done as well? What is the nature of selection as we evolve from the space station standards to a lunar standard to a Mars standard? So I'll open that up to the committee and see if Smith has any thoughts on this as the lead in selection, and Vladimir, I'll ask your comments in a sec.
Yes. All the above. No, it's standards are simply risk mitigation. Risk for bringing someone into a career for 10 to 20 years of a career that they don't have a disease process which will manifest itself and be a burden to the medical system and have an impact to the mission. The mission, of course, is a short duration mission, which is shuttle, 2 weeks, Soyuz dock missions, 2 weeks. And I think we've got a pretty robust, a pretty good system for that. I think we've got good training. I think we've got good supplies. And I think we've done well with that. The long duration, basically the standards we have now look at 6 months. That's our sort of standard of care for being in orbit, and possibly even longer. And that's what our moon mission is. So we're very rigorous on our selection. We are also very rigorous on our long duration folks that go up. Astronauts are like everybody else, and they get sick. And we've had many instances just in the last 4 or 5 years of 3 cases of atrial fib, 2 cerebral vascular accidents. We've had multiple GU and GI cancers. So you're looking at that individual who, all of those people, we would still fly on a short duration mission to the ISS on a shuttle or do a Hubble mission. However, you're now talking about long duration. You're talking about 6 months, and I'm talking moon, I'm talking ISS, and therefore you're putting those people at a longer interval of time up in space. So you're worried about somebody. Anyone who's had a cancer is probably not going to fly long duration space. Anyone who has had a degenerative disease that we don't know the outcome of, that we're screening them every 6 months, they're probably not going to fly in long duration space. Anybody that's ever had a kidney stone will never be in the astronaut corps because they have a 20% chance over the next 10 to 20 years of having another stone. However, we might be able to prevent that stone, but we still would not want to put that person in the environment of the long duration space where is the calcium from your bones going? It's going through your kidneys. Anyone with, again, these are radiation workers. We're putting them in a very hazardous environment with our radiation. We are very concerned about that. The Flight Medicine Clinic, not only for the mission duration, but even more importantly for the long duration health of the crew members. So when they're in their 60s and 70s and 80s, they're not getting the cancers, they're not getting the leukemias and that sort of thing. So our standards, very good points, Dave. Our standards are very strict for selection. They're very strict for long duration. They've been vetted by our international partners. All of us have a representative on the Medical Standards Health Evaluation Working Group, which started in 2001. We've developed 3 standards documents. We're changing those. The biggest areas that we'd like to look at are, of course, imaging, which helps us. I mean, we didn't have the ability 4 or 5 years ago to cure atrial fib. Now that's a standard of care. We've done that for 3 of our astronauts and 1 of our flight surgeons. We didn't have MRIs up until recently, and now we have the ability to use those MRIs to screen people more effectively who are at higher risk. The big question, and we actually have planned this fall to have an imaging summit to look at what the latest and greatest is out there. Those are very important modalities, and it's changing very quickly. We can now, the gold standard for coronary disease was to do a cardiac cath and to squirt dye in the artery and see if it lit up. Well, we now know that you can have advanced disease, advanced coronary disease, and have normal coronary arteries. And now we have the ability through calcium screening. We do electron beam CT screens on all our astronauts and all our long-duration flyers. We'll be doing that on selection. We do MRIs of the brain, where we have found, the German Air Force actually was the pioneers in this, and they found about 1% of their candidates had a significant problem. We've already found an aneurysm that's been fixed. We've already found a benign brain tumor that's been resected, and now that person is going to be qualified to fly. So these sorts of things, risk mitigation is what we're after. Now the big bugaboo that's coming down the road that's really, I think, going to help us, but it's also going to give us a lot of heartburn with a lot of things, and that's genetic screening and how we use, how we're going to use that. I'll give you an example. If you had somebody that had a BRCA1 or 2 gene, they have an 85% chance of having breast, colon, or ovarian cancer in their lifetime. Are you going to send this person to Mars? Are you going to send them to the moon? Are you going to put them out of low Earth orbit, out of the Van Allen belt? Or are you going to give them those radiation doses? And I don't think we have the answer to that yet. And I think as we get better and better with our genetic screening, that may be able to help us. Right now, the way we use genetic screening is if there is a significant family history, we're going to test for a BRCA1 and 2 or a Lynch syndrome, which is someone who's predisposed to colon cancer. And we're going to say if you have that, we may not exclude you from flying long duration, but we're going to give you the informed consent that these are the odds down the road, as best as we can come up with, for you developing this cancer or this condition, and we're going to screen you much closer. So that was sort of a flight of ideas. Did I answer any of those questions correctly?
Very good.
Sorry.
Jean-Marc wanted to add to your flight.
Yeah. Yes. First of all, I think medical standards is only part of the answer to what we're discussing. First of all, we have to remember that we have achieved something great on the ISS program in that we took, 5 different partners with different standard of care, multiple medical standards, and we were able over years to unify this in one standard that is used by all IPs. Medical standards are constantly evolving, and we are using, and we've learned that from the engineers, evidence-based risk matrix looking at each conditions, the risk of occurrence versus the impact it will have. And this is one of the great progress we've seen over the last 2 years in how we do business with the ISS medical programs. However, you cannot look at standards in isolation. I think you need to also consider concept of operations. Concept of operations will somehow drive the standards by which you will operate. And if there's a change in your concept of operation, for example, if initially on the ISS program, any medical issues we would have on the ISS, we would medically evacuate back to Earth using the crew return vehicle. Simple. As a result of that, we'd had relatively limited facility on treating any medical issues on the ISS. Well, the concept of operation has changed because of programmatic reasons. So the crew return vehicle is no longer available. As a result of that, we are stuck with very difficult decisions. And perhaps this is driving the medical standards in a more restrictive area simply because of the decreased capability we have on the ISS.
Volker, would you like to add to that?
Yeah, I think health is defined by mental and physical well-being. So we have to be careful that we are not excluding psychology and psychiatry. We have profound psychiatric no-go criteria and selection criteria. What we are still lacking is, and I come back to what you said yesterday, Dave, what makes a good astronaut? And it took you quite some time to define what is a good astronaut, but also in terms of cognitive function, cultural capabilities, leadership, followership, communication skills. That is something where we all have a rough idea what makes up a good astronaut, but we don't have any criteria. We have not gone back into our previous selections to see, okay, did we really select the right people that are capable of going on a long-duration space flight, go to Mount Everest or go to the Antarctic. So there is many examples and many data available. So that is certainly one element that we also have to look more closely into when we define the long-duration selection criteria for.
Yeah, excellent point. Smith?
And one other final point for screening and care is lifetime, is really long duration. These people have been radiation workers. They've been put in very unique environments, and we've and back to your discussion of the psych, we've had a couple of folks fall through the cracks who've left the Corps, some of which is, I would say, have been a little bit of our fault. We've recently lost someone at a very young age to colon cancer, and we've lost someone to suicide. So I think we need to be very proactive in the flight medicine clinic and amongst fostering the information that we need you to come back and do your longitudinal health study evaluations. We need to supply medical care for a long term for the rest of these folks' lives. Anybody else want to comment on that?
Well, thanks very much, Smith. You know, for a 4-year period, I was Director of Space and Life Sciences at Johnson Space Center, and I had the honor of being able to work with this team on a regular basis. And I can tell you that as a crew member, I really appreciate the tremendous work that's gone into thinking about the standards and the true desire that the flight surgeons have to keep astronauts and cosmonauts flying. We represent a skill set that's very unique. When you've flown once, twice, 3 or 4 times, you start to acquire the skills like Dr. Polyakov to be able to live and work in this extreme environment. And of course, the goal of the flight surgeons and the team is to keep us flying. The question that I would then throw back to the committee is, as we look at going to Moon and Mars, we talk about the benefits of flying older astronauts. I'm 53, I'm still young, you know. I'm thanking Senator Glenn for flying at age 77, extending the capability out there. So the question would become, if we were thinking about going back to the Moon and on to Mars, would we really be able to accept the potential medical conditions that we have in that environment? Dave, did you want to add to that?
Before you move on,
Yeah.
I think Walt has
Oh, well, yeah. Go ahead. Sure.
Thank you, Dave. I know this is a medical conference, and therefore everybody's interested in providing the best medical care you possibly can. But I think you ought to have a long list of medical conditions about which you can absolutely do nothing, and buy off on those very early, because any conclusions you make have a cascading effect in terms of training, equipment, stowage. I mean, all of these things which are basically kind of out of your control, but you will impact all of those things. The Air Force had a saying back in the 60s and 70s, you've got to expect losses. And I think that you're in a business where you've got to expect losses and buy off on them early, because there's a price you pay for progress and there's a price you pay for exploration. So gilding the lily is not a good answer either.
No, I totally agree with that, and that's why we had a fairly large rejection rate at our last selection board. Most of it was on vision, and I think I've changed some of that, but we're very strict on selection. In fact, every one of our standards, we do not waive on selection. So all our standards are written so that if you have this condition, you're disqualified. You'll not come in for a career. Once you're a trained asset, once we've invested the time and energies, and then we'll consider wavering something. So somebody comes in and they've had 2 knee surgeries, then that's not a smart thing to do down the road.
I don't think you and Walt are on the... To be quite honest, you're going back to what John was talking about earlier. I think Walt is saying we have to accept the fact that there are some things we either can't... Oh, I'm supposed to wait. I know that.
Yeah, we'll try and make sure we use the microphone just so that for the translation.
But we're trying to record it.
Yeah. And
the translators. But Irina knows she's got it. I was saying, I think Walt's comment, I think, is not about what you were saying about selection, Smith. It was about coming to accept the fact that there are some things that we either cannot cure, solve, do on orbit, or treat, and we should compile a list of what they are. And let me I'll give you an example in looking at the upcoming Hubble mission. It has nothing to do with medicine, but we said in an advisory capacity, there are some things that we don't launch for today that if we're doing a rescue mission for Hubble, you want to not even think about not launching for it because this is a life or death situation. There are some medical emergencies, if you will, or some medical things that may crop up that you say, hey, we'll do all we can with what we have, but we are not sacrificing the mission for this individual because the long-term chance of survival anyway is pretty slim. We get into medical ethics. So I think that's what Walt was addressing. Try to wrestle with the medical ethical problems before we have to sit around in mission control in the back rooms and make decisions. I think that's
You may not want to abandon the International Space Station. Everybody is sick.
Oh, yeah.
I agree there.
Yeah, and that's a very tough question that we're going to have to look at, particularly as we get farther away. The same question could be raised of a lunar habitat. Right. Nessa had a question, then Dave had a question.
Very quick on this topic.
While we're getting the microphone to Nessa, Dave, go ahead.
I totally agree with you, too. And you can make the standards so strict that nobody passes. And before you get to that point, you're going to have it so strict that no one you want to passes, or not enough that would be good astronauts. So we're going to have to balance this. And you can make the capability so high that you can't fly a spaceship. You're flying a hospital, and you have to balance with accomplishing a mission and accept the risk. And these judgment calls are, I think, what you guys are talking about.
Inessa.
I think that, again, we have a lesson which told us that additional to all type of screening which now cosmonauts are going through, there is one line of screening is missing, at least on our side. I don't know about American, but on our side. It is screening of genetic build-up of the person. I will explain what I mean. From sport physiology, we know very well that genetically people are divided on sprinters and skiers. Sprinters are organized. It's not their guilt or advantage. They're organized in such a way that they're very good in solving all the acute situation. They are very fast, usually, not only in muscle, but they are fast in all system of organization, control, and so on. Skiers, but they have disadvantage. They're not very good. I wouldn't say very bad, but not very good in monotonous situation. On the opposite, skiers are going slowly, but for them, monotonous situation is suitable. Why I said that we dropped in such situation once, and it was very heavy situation. One of skiers, excellent testing pilots, was sent on a long duration mission for 8 months mission. And he couldn't make it because of stress. For him, this situation was stressful. And finally, the mission was interrupted. There was just some small episode which already completely destabilized him, and he developed all picture of heart incompetence, heart deconditioning, and we had to interrupt mission. But when he came to the ground, it turned out that he didn't have heart deconditioning. And it was very funny that Dr. Gazenko, who was director of the institute, sent me to the main constructor, our main constructor, who was furious on medical. He said medical couldn't make proper selection. And he was furious with this cosmonaut. And I had the mission to explain to him that he didn't have to be furious on cosmonaut. It was a proper reaction for this particular man who was excellent sprinter, but not skier. For exploratory flight, this type of screening should be developed. It will have I would say, the priority line of screening, because people who would be sent for such mission should be skiers.
Thanks very much. Selection critical area. The next phase of prevention, we're looking at selection as our primary prevention. The next line of prevention is basically in developing countermeasures. And we've worked very, very hard with the NSBRI over the last 10 years looking at developing countermeasures to prevent some of the deleterious effects of flying in space. And I'd like Jeff and Judy and John to comment on the current state of countermeasures that we've developed on board the ISS, and to start thinking about those countermeasures relative to exploration, because one of the challenges that I think is going to happen over the next few years is we're transitioning from station back to the moon. I like to say by the 50th anniversary of Apollo 11, having humans back on the surface of the moon. In so doing, our zero-G capability may disappear. Our zero-G research capability may disappear at the station. So when we transition from the moon to Mars, what research platform are we going to use to develop those zero-G countermeasures for Mars? Or is this what we're doing on the space station right now? And if so, are we learning the lessons that we need to get humans ready for not only voyages back to the moon, but voyages on to Mars? And the last question I'd like the three of you to consider is, when we develop countermeasures, do we develop a breadth of countermeasures for everybody, that it's, kind of one-stop shopping? There's your muscle countermeasure, it's an off-the-shelf countermeasure for everyone. Or should we be looking at individualized countermeasures, developing a specific plan that differs depending upon the crew member, their age, their gender, potentially even their genetic makeup and their vulnerabilities, to optimize their capability to perform in space and to recover? So for Jeff and Judy and John, I'll open it up to you and have you comment on that.
I'll just quickly review what we have now, and then maybe get into some of the more speculative parts of countermeasures. But right now we have on orbit, internationally, we have actually a fairly nice suite of a treadmill, two cycler ergometers, and resistance exercise, as well as a new flywheel device that ESA has provided. And I think we're doing fairly well. The hardware itself has had to go through a process of shakedown, and we have had some hiccups with the hardware where we had to do a lot of repair. The reliability has not been what we would like it to have been. Currently, the crew members are allotted 2.5 hours of exercise a day, and that's not all exercise. Part of that is setup and tear down and cool down. But generally, we have been quite successful at doing cross-training with treadmill and with resistance exercise and cycle ergometry. We do some in-flight physical fitness evaluations so that we can track them during the flight and adjust countermeasures as we go. We have, at least on the U.S. side, and on the Russian side, we have a little bit different philosophies as well as ESA. But but our ultimate goal is to enhance health and performance. We need to do a better job at optimizing those countermeasures and the prescriptions, and being able to reduce the amount of time and hardware overhead that's required in order to sustain the crew health. I think that we've learned a lot from each other in the station, and even during MIR, we've learned, I know that I personally and NASA has learned a lot about countermeasure development, use, and how we can optimize crew performance and minimize the rehab period. As far as our approach, we have a general philosophy, but we individualize the actual prescriptions of how we approach across training of utilization of those devices. And we have a lot of individual variability, so we have to individualize things to a certain extent. We don't feel like we have completely solved all the problems. We need to refine some of our prescriptions to do better, to be more efficient with addressing the muscle strength and endurance and performance issues. We feel like we're closing in on the bone issues, although we still have some bone information that we need to address. We're getting closer with pharmacological countermeasures, and possibly the use of pharmacological countermeasures as an augmentation to what we do with exercise. We hope to fly an advanced resistance exercise device in the fall that will give us higher loads and more capability that hopefully will address some of the bone and muscle issues. We feel confident that that will work well. But of course, flying it, we'll find out soon. And we still have to address some of the cardiovascular aerobic conditioning seems to be going quite well, actually. And the crew members are able to maintain their aerobic condition during the flight. As Anessa brought up yesterday, is the neuromotor system, which is definitely a challenge with the kind of hardware that we're flying now. We have some challenges in how to address that from a countermeasure. We have a long road to understand that better. So with that, that's essentially the current state. I don't know if Dr. Kozlovskaya wants to add anything to that from her perspective.
I would rather not.
Okay.
So Jeff, looking at some of the challenges Judy has outlined, from a research perspective, how is the NSBRI able to address these?
Well, I think that what the NSBRI tries to do is to leverage off a huge investment that's being made in the area of medical advances, and quite a number of these pertain to countermeasures and also to emerging technologies in the areas of imaging, for example, and also not only in genetic assessments of risk and vulnerability, but also in personalized medicine and the delivery of care that may differ from individual to individual. So, what we try to do is to work the best we can in partnership with NASA, and to also be aware of quite a number of other developments that are taking place. As far as the suite of countermeasures that exists, we have about 60 projects right now that are in our science and technology portfolio. The majority of these obviously are ground-based research and development projects that John had alluded to on the panel yesterday, moved through a pipeline to testing and evaluation and then operations. And so these projects are all listed in the public domain, and we're very excited by a number of projects that are making their way towards the station. We see the station as absolutely a precious international resource that we absolutely have to capitalize on, and the international community really needs, I think, to have a return on the investment. This is amazing engineering construction project, 3 laboratories, and it would really be a shame as we move and look, of course, to the moon and to Mars to not take advantage of the capabilities that the station has to offer. And I look out in the audience and I see Dr. Soller, and I think of her non-invasive techniques for assessing blood and tissue chemistry, watching this project mature, and the capabilities that that technology offers to have it move to station for testing and evaluation, to help with optimization of exercise countermeasures, and also to look at the assessment of injury. And I think it speaks to some of the earlier issues related to, I think Nick Canis brought up, of a surgical assessment situation. And I think that the capability to have accurate knowledge that can be assessed in an autonomous way is absolutely critical for decision making. And so this is an example of one project that is making its way towards station. I think we absolutely need to, again, to capitalize, and I'm very excited by the suite of technologies that exists. So I could go on, but I think that addressing the three main points that you have, there is a very vibrant, active suite. We've worked very hard to ensure that the current and former astronauts and the flight surgeons and the operational folks have a say right at the very beginning in terms of operational need, of operational feasibility, of strategic need, and work with NASA in terms of the prioritization of what we're soliciting for, so that there's going to be useful outcomes. That there's a critical mass of projects that are maturing. There's an engagement of internationals, of students, and I think that the personalized treatment is really paramount, of high priority, and we've actually funded specific projects. I know Dr. Dinges looked at various vulnerabilities, so I think it's a very exciting time, actually.
Excellent, thanks. John, maybe you could... Okay, well, let's let John add a little bit, and then we'll get you a microphone so you can ask Jeff a question. Okay.
Well, as always, I'm going to try to stir up some controversy. I think it's extremely important for us to start working closer with the mission architecture folks and the vehicle designers, particularly now because we are in a new mission architecture and vehicle design phase. And so what we have to do is look at what do we bring to the table, and I'll focus on exercise equipment because that's an easy one to pick on. What you have to look at is to try to turn a downside into an upside. Now, right now, the downsides for exercise countermeasures are crew time, not just in actually doing the exercise, but the repair times. The increase in consumables, such as because oxygen consumption goes up and CO2 production goes up, which have to be accounted for. The fact that you now have a heat load that you have to perhaps dissipate, and the motion dampening is a significant problem on the space station. So what we have to do is work with our engineering and mission architecture folks and try to turn a downside into an upside. Perhaps one of the most inspirational things I've seen is that Mike Gernhardt's small pressurized rover has this FRED concept, the Fred Flintstone, where basically if you're trying to do something like get somewhere, you're actually using some of the human power to do that, and in the process accomplish some of the exercise requirements that we have. So that's the challenge for us, is to start thinking about new ways of doing things and trying to take advantage of a downside and turn it into an upside. And perhaps that means some novel ways of energy storage, so that if you're going to do a cycle ergometer or some kind of exercise device, that you're capturing the energy that you're expending, at least in some way, so that you're recovering it and not just wasting it. And it's all those downsides that really add significantly to the mission, because you've got to carry more consumables, you've got to dissipate heat energy, you've got to dampen motion that you have from your exercise equipment. So the key thing for us is that in this new mission vehicle design arena is to start thinking of ways that we can turn downsides into upsides.
Thanks very much, John. Inessa, your question.
I have just a question to John. Since you are the leader in new projects addressed to countermeasure, I have two questions to you. One, do you have projects which are addressed to developing countermeasure for motor control? I was very much infatuated by the movie which John Clark showed us about locomotion and movement on the moon. And as a matter of fact, as scientists who have some knowledges, we predicted it, because many years ago there was a done experiment in which people studying the motion of people, including locomotion, in situation when the weight was taken out on the ground. And it was already seen how much this control going down under this condition. Now it was shown that on the moon, a very poor in their locomotion. And they're, as a matter of fact, very poor after long duration flight, even on the ground. And we know that our people who come from long duration flight, if they are not found in time, 4 hours later, they found still laying down on the ground, which is impossible on the moon. So my question is, if you succeeded, because we didn't, in developing new approaches and a new countermeasure line to counteract motor control and at least to monitor properly decline in motor ability of people, because on our space station, including our common space station now, there is very nice monitoring system for heart rate, for respiration, for whatever. But you will not diagnose neurology sign because there is no means for diagnostic of this sign. There is no mean for diagnostic of declined motor control abilities of people and so on. So maybe, if you have such project, I will be very happy because we are working now in international world. So if you will develop something meaningful, it will be good for all of us. And the second question is, coming from what John said, that besides our own ability, we should use those technology achievement which can help us to a great extent. So the question is, if among your project, there are projects which are directed to develop the system, very elaborated, very high-tech system, which will help doctor on one side, doctor of mission on one side, and our cosmonaut, astronaut, to diagnose himself. That is to your answer to your question, that something is not very right with him, and help to diagnose, and even maybe the technology today already in clinic allow not only to diagnose, but to tell him what to do next, especially at least for countermeasure system, but maybe for medical system as well.
And I think that the answers deserve more time than what we have here. So I would love to talk to you more. But let me just briefly address the two questions. First, in the area of motor control, the way NSBRI is organized is that we at present have 7 science and technology teams, and 2 of the teams really speak to the areas that you've talked about. One is in the sensory motor area adaptation team that we have, and then there's one that's musculoskeletal. We've combined the bone and muscle teams, and there are projects that address some of the topics that you've talked about. I think that what we have to keep in mind is that these physiological systems are integrated. That vision, for example, becomes very important in looking at motor control on the surface, and we actually have a project that's a new project that is looking at that. So I think that we recognize that this is a very important area. I don't think that it's a challenging area. I think that there are gaps, and that there is work that we need to do that we're currently not doing. What I would very much like to see is more discussion among the internationals, in much the same way that we have representation here on this panel, in really scoping out high priority research projects that relate to space medicine issues and countermeasures, that in the planning and in prioritizing what it is that we really want to do, that we have perhaps a little more open mind than what we've had in the past. Speaking, I think, to the second issue of smart medical systems, we do have a team in this area that we've now combined with technology. We've identified, I think, and has as a high priority from very early on, the need to have systems engineering and smart medical systems per se. What we have solicited for this repeatedly, and unfortunately, we have not really had the response that we would have liked to have seen. I think we've had an outstanding response for individual components of the system, of technologies that have smarts built into them. But in terms of having integrated systems that really come together with diagnostics, treatment, capabilities that interface with the crew and the ground, I think that we still have work to do in that area.
Now, Larry has a comment, a question, but I'd like to ask Vladimir, from your experience, how do you feel the efficacy of the countermeasures is? Are they working successfully? Do we need to improve in certain areas? What do you think the focus should be?
Позвольте, я на один вопрос вернусь.
Well, I would rather go one question back because I wasn't able to offer my comment at the time. And with respect to the selection of the crew members, when you do the calculations of the probability of an urgent medical situation that may arise on board the station, if we go back to the beginning of the professional activities of each cosmonaut, he of course goes through initial screening, initial selection, and so starting from that point, his subsequent life as a professional is constantly controlled and monitored during the training and during the actual spaceflight. During the post-flight period and measures taken, it's a very important point. We consider that rehabilitation is a set of measures that is performed post-flight, and even after the end of the cosmonaut's career, we have undertaken the responsibility to make sure that we perform the periodic screenings of the retired cosmonauts, the ones that are available to us in Russia in terms of performing medical examinations and control. So at the selection stage, we presume that what we are seeing there is young people, fairly well educated and having a desire to employ themselves in this professional activity. So in the Soviet Union and then subsequently in Russia, the main core contingent came from the military, pilots primarily, and people who are involved in the space and aerospace industries, such as rocket and missile specialists and space medicine specialists also. So these would be the three main sources for our troops. And so from these sources, we got quite decent professionals. We had relatively few issues in terms of selection. Of course, we do, everybody who does anything encounters problems, and sometimes we missed some cases. The latest case, you know, in Expedition 18, we had to replace a crew member due to health concerns. We had issues in terms of returning crew members from orbit because of health problems. And we consider that our activities are rather positive and effective based on the experience of the long duration of flights. And the longest flight ever in the history of manned cosmonautics is indeed our colleague. It's a doctor, a professional cosmonaut. And the reason that when I started suggesting the issue of who is going to be flying to Mars, it's the professionals that are going to be flying to Mars. And so there's a dual understanding. Do we need a doctor there? It's true we do, but whether we would be able to use just one setup in order to have a doctor fly, I'm not sure that the flight directors and the management would approach this problem. So we need to make sure that we have redundancy, that we have at least 2 medical specialists, medical officers that will be on a long-duration flight. So with respect to the medical monitoring and control, on board the station, we have a system that showed fairly good results. There are certain problems, perhaps, but on the whole, the evaluation of health status by using Russian and US assets on board the station enables us to be rather certain in terms of controlling the state of health of the crew and making sure that we provide the consultations for those on board the station. And the main element that has access to the crew is a crew surgeon, and we have quite a few colleagues at this desk who have gone through the same school, and we understand that a lot depends on the crew members who are flying and on the person who's working in the mission control, specifically with each crew member. So, with respect to using the countermeasures on board, I can say with certainty that they are useful. In the presentation, in Dr. Kozlovska's presentation yesterday, she mentioned that after 17 days of flight, crew members were not able to stand up unassisted. So there were certain problems, and they were half alive, really, only halfway alive. And so the system that we have now on board as a set of countermeasures, our colleagues have outlined those means. It's the treadmill, the stationary bikes, the resistive exercise devices of different kinds. And in addition, we have more capabilities. At the initial stage, we use the bracelet item that provides for the more adequate liquid shifting in the body. It's quite a useful device. Now we have also developed the modified variety and understanding of knowledge of the redistribution of blood in the body. There is a joint experiment, Adam, which uses ultrasonic diagnostics during spaceflight using this method. And we also have another magical thing, an electromyostimulator. It enables to maintain the muscle tone for a group of muscles, either by choice or by recommendation of specialists from the ground. There are several varieties. One is called the tonus, another one is called the stimul, which is the low-frequency electrical myostimulator. And in addition, we have a pharmacological means to assist in case of motion sickness, for example. We have other means that would enable one to help the cosmonaut to recover after a long-duration spaceflight. There is the suit called Centaur, which also shown fairly good results during landing. And we should not forget, and we perhaps are forgetting, that we have our rescue vehicle, which is a Soyuz, which is constantly there with the crew, and is the basket that would take. It's a basket in which we put our precious eggs, you can say, eggs being cosmonauts and astronauts, and brings them home very carefully so that they could receive the necessary help. And this thought that we need to understand, we should preclude the possibility of developing a situation when the crew would have to be returned from orbit, because that means that we are not working well. The entire set of our activities, the countermeasures and pharmacological preparations and means of hygiene, environment, need to create conditions such that would enable the crew to stay on board the station for a long time and complete the tasks that they need to complete. As soon as we have to bring the crew home, so that's like you got an F in doing your work. So we need to discuss the situation and measures that we need to preclude the possibility of having to do that. So I would like to stop there.
Спасибо большое. Larry, you had a quick question.
Yes, as happens so often in high-level meetings, Inessa Kozlovskaya cuts directly to the critical question. And the question there this time is countermeasures in the context of lunar operations. And if we we're all aware of the fact that we have a unique opportunity in returning to the moon for long durations to use the 1/6 gravity of the moon as a way of understanding sub 1G gravity and extending it to the Mars duration. We also have the challenge of adequate countermeasures to assure the safety and performance of our astronauts during the 6 months or so on the surface of the moon. Now, it's been expressed by some that this is a non-problem, that merely the exercise associated with periodic EVA excursions in the EVA suit will be sufficient, which may very well be true for cardiovascular. A number of us doubt that, but one thing is certain is that we don't have the evidence either way as to the adequacy of this EVA suits alone as a countermeasure or other required countermeasures for the moon, and I would like to hear from some of the panel members with respect to this question.
Hey, Rick?
Well, thanks, Larry, for bringing that up. I want to reemphasize what John said about staying, really focus on what the mission architecture and the vehicle design is, because that's the world Jeff, Pete Bauer, and I live in right now, is justifying what we're doing based on its operational need. When I go and try to argue for our exercise equipment and say, well, crew members lose 20-30% of their, lower body muscle mass, the question that comes back is, has a mission ever been, terminated early because they did that? No. Has any crew member ever died because of that? No. So it's hard to justify using that countermeasure in the environment where, for us, it's just something we'd like to have. The crew members would like it for other reasons, including certainly a lot of things the Apollo guys said, just rest and relaxation stuff. But that carries no weight with the vehicle designers. However, now that we're getting the mission architecture, an example of something that would help us work on something with the countermeasures would be, for example, in the water landing scenario, if there's an unaided egress scenario, the crews would have to actually unlatch a 115-pound docking hatch and physically lower it to the deck. Now, I think that would be quite a challenge with the things we know about muscle loss, loss of motor control, et cetera, et cetera. So what critical mission tasks can we define and then design those countermeasures around? Then we have our justification with the vehicle designers to actually carry that stuff with us, because if it could result in loss of mission, most likely loss of crew, less likely, then if this can make a difference and to study that, that's really where we're going. A lot of this kind of interesting academic stuff carries no weight on the engineering side, so we need to define what the critical mission tasks are. We're getting that information more now, what the vehicle designs are. The lunar architecture teams defining what eventually will be the lunar surface activities. Then we know what our hazards are and what our risks will be, and then we design our countermeasures around that. Then you've got a sound case for designing these countermeasures. Otherwise, I can tell you, Constellation program is not, and right now, our countermeasure capability as far as like exercise goes is about 20 pounds for a piece of equipment. And last I checked, there's no piece of equipment that will meet our requirements for muscle strength, stamina, neurovestibular control, et cetera, et cetera. So we're living in a pretty constrained world. Jeff, I don't know if you had anything to add to that.
Rick's right. For the short duration missions, that's all we have allotted in our mass allocation for exercise. For longer duration lunar missions, the habitat, we have a larger exercise complement that we'll be able to implement. And Rick's right. It's preserving mission critical task is a key component to those countermeasures. But also we need to remember optimizing crew performance is also an objective we need to maintain. We want those crews to be able to complete those tasks in the minimal amount of time with the maximal effectiveness and efficiency. And for them to be able to do that, they have to be a well-honed, tuned, fine machine to make that stuff happen. And we can't maintain that kind of performance level if they're degrading in their muscular endurance and their bone mineral capabilities.
And if we can demonstrate, objective, quantitative evidence of what the performance decrement is and how our countermeasures enhance that or maintain that and how it ties into a critical mission task, then we've got what we need.
We'll take one more question on the countermeasures, and okay, I think we'll take two more questions. Yeah, go ahead.
Thanks. As I listen to this, it strikes me, this last comment by Dr. Shearing is very illuminating. With respect to lunar outpost missions, with a long-term stay, from what you just said, is the performance objectives the only concern? In other words, I don't hear any room for concern about long-term astronaut health and countermeasures that may impact on long-term health. A specific example, you lose bone mineral density, it doesn't impact on performance until you get to the worst-case scenario, say, of a fracture. All right, so, but in the meantime, it's not going to impact on performance. It may impact on long-term health, particularly upon return. Is this anywhere in the talking agenda for lunar outpost missions? Long-term health issues?
Sure. The bone problem is you maintain the bone. You're not really worried till you come back to Earth, and then you're able to put the bone back on. So my real big concern is radiation and down the road from the radiation environment. And neurovestibular, I think, was the other thing. That's what I think we need some effective countermeasures for. I think that's what we've been talking about here for the last 20 minutes.
You have to make a point that long-term health is important.
Definitely. That's what I've been saying from day one. That's what I said, for the rest of their lives, for sure. Yeah.
Dr. Longnecker.
You're right. Their concern usually is
Considering what they're dealing with, having a vehicle 1,000 pounds overweight, and the alternative is you don't launch and that's it, they're not looking at long term. It's how we get this vehicle off the ground, again, because it's driven by the fact that it's about the mission and not all these things that we're talking right now. I mean, I'm sorry to bring that out, but that's kind of the hard reality.
I think one other thing, too, regarding long-term health is we don't know how much the lunar gravitational field will actually help in sustaining some things like bone density and other systems. So I think it's probably something that we're going to have to study further, is what those effects are. And that's going to be a direct effect on what we end up taking for countermeasures. And we know we have limitations, so we have to probably focus on the things that we have to protect. So
we had basically lost the exercise capability argument here until we went before the CV vehicle integration group and said that unless they can guarantee 100% that the crews will have an aided egress, then we have to protect against unaided egress, which they can't guarantee. So because of that, we know that we can improve strength, stamina, et cetera. That's how we won our argument to get the exercise capability for CEV, but it was in terms of hazard and risk that allowed us to do that.
And nominally, we probably do perform well, but in those emergency scenarios where we have to tap into our physiological reserve, as we decondition, we lose a lot of that reserve. So we have to define what those needs are. I'm sorry.
We've got 3 questions. We'll go 1, 2, and 3. Okay, so.
Well, Judy just sort of teed up my comment, which is more of a comment than a question. But we know that most biological systems are not linear. And we know that at the moment we have 2 data points with regard to the effect of gravity. It's 1G and essentially 0G. And I just want to emphasize the concept that 1/6 G, we don't know. It may do nothing, but if it's a sigmoid response, it could be well on the ascending limb. It may be preceding the ascending limb. If it were on the ascending limb, just for the source of discussion, that could change entirely our approach to architecture downstream for a 1,000-day mission, for example. It might raise the issue again about partial gravity again, if that were the case. So I just want to make sure we don't get so enthused about our countermeasures that we apply them as if we were in 0G. And that speaks to the necessity, of course, then to have an on-site, ongoing lunar laboratory to evaluate biological physical performance.
Yeah, one of the things you talked about was genetic screening, and I think one tool that's going to be available probably fairly shortly is, instead of just looking at genetic screening, look at genomic response and the proteomic response. That's the genomic response of messenger RNA in white cells and peripheral blood mononuclear sites, and then looking at also the plasma proteins and how they respond to exercise, to countermeasures, to other environmental insults, because those give you very powerful signatures often of what's going on. In fact, we've got some preliminary results that shows we could even correlate some of that with CT angiograms in terms of what the soft plaque is. And in terms of being able to use that as a tool to look at things that will give you coronary disease or other risk factors decades down the line, and being able to intervene in those very, very early. I think that will eventually become a very powerful tool to assess risk and take some corrective action very, very early.
There's an article in New England Journal just published about the biomarkers for cardiovascular risk with troponin 1 and cystin C and CRP and others that are being able to project way out there. So, yeah, we're following those.
But there are many that are probably even better than that. That will be coming along shortly, I think.
Yeah, one question maybe is just to clarify a little bit the architecture and the limitations in terms of upload mass for countermeasures. So the limitation we are talking about is for Orion at this stage. So definition of Altair and outpost is still in the air. So maybe one possibility is you start building up when you define Altair, you go to the sortie to outpost mission, and maybe your limitation will be kind of defeated because you are building up capabilities, and as you increment missions, you can add more hardware, more requirements, and for lunar outposts, you have the luxury to have a little more complete suite of countermeasures. So I think what you're referring is the first stage, Orion, limitation on capability Orion at this point. I'm right?
Modules added in the outpost phase that will allow us to build capabilities for exercise and other key human physiological needs. And so we are staking off some real estate in that outpost scenario. So not for sortie missions or short duration flights in multiple locations, but as we build an infrastructure on the lunar surface, exactly the point that we'll have more capability.
And what is your estimation of the build-up? How much you think you can put out there for the lunar outpost?
Well, those basically half of a module. What we're talking about now, the latest iteration of the lunar architectural discussions, this trade space 3 that we're talking about now, includes 3 lunar outpost modules. One that will be called the core habitat, one that's the EVA and geologic sciences, and then another one that includes life sciences, exercise, and medical hardware. So
now we have one question in the back, and then Dr. Petrov, and then what I'd ask you to do is we'll hold our questions for the end, the further questions, but just these last 2 questions in this area so we can proceed on. Go ahead.
Well, I actually don't have a question. It was more of a comment. I've heard a lot of discussion about different countermeasures. I have not heard much discussion about behavioral health countermeasures, and long-term, post-flight rehabilitation in terms of behavioral health is a very important concern, especially for a daunting mission like a Mars mission. The likelihood of a behavioral or psychiatric problem during the course of such a mission is quite high, actually, in a crew of 6. You can almost expect that there would be some kind of a problem. And of course, post-flight, once they're back, we heard yesterday, we heard the speakers talk about post-flight rehabilitation, problems that happen when crews return from space flight. There's a whole a number of very important countermeasures that the behavioral health program is working on, and a lot of those are are going to be tools that we hope that we can aid the crew members for, that would provide feedback about behavioral health, that would be able to detect early any kind of signs or symptoms, so that if there were to be an intervention, it could happen quite immediately, so that we would prevent any kind of problems down the line. So I just wanted to comment on the fact that I hadn't heard anything about the behavioral countermeasures. And I do have one question, and that would be, in terms of selection, crew selection, what are your thoughts about selecting for compatible crews? To the panel.
Rick, you want to?
Well, I was just going to say, we actually posed this question to Apollo, and their response was, none of those things mattered as much as the crews understood authority structure. That was the key for these longer duration missions. And it didn't matter if they were all men, all women, half men, half, well, not half men, half women, but 3 men, 3 women, et cetera, et cetera. Authority structure was the key driver for picking our long duration, our Martian crews.
You're going to select very capable people, and you're going to be monitoring them for years until they get their first mission. So I think you'll be able to put those the proper folks together. Concerning your question about countermeasures, on Expedition 16, it was the busiest mission we've ever had. We had 3 shuttle missions, ATV, and my biggest concern throughout the mission was fatigue avoidance, and we had to do a double slam shift, which was not only tough on the crew, but it was really tough on our ground forces. And so we've even talked about putting some active watches on our ground forces. They are shift workers. They do get 5 to 7 hours less sleep a week. We do have some ground control teams that have 2 to 3 times the hypertension and diabetes load they should have, and we also take care of those folks too. So that would be something that I'd like us to look at in the future. I think we can individualize a person's response to different sleeping medications, alertness medications, melatonin, circadian shifters, how they respond to light, and they're great models out there, but a model's not really worth anything because John is very different than me, as far as how we would handle.
Not really.
Okay. How we would handle certain things, certain medications, that sort of thing. So if you could take those models and you could take an individual and test them in a lab and know how they respond to these different things and then individualize them to that model, then you've got that person's profile. And so when they get up in orbit and you have to slam shift them 12 hours, or 9 hours, which is what we do when we go to Russia or when we come back here, and that's a great analog system to look at how you respond to different medications and light and that sort of thing. So that would be something that I would like to see some efforts put into.
Excellent. Dr. Petrov.
In light of Moon and Mars mission, can somebody give some comments about role and method of using the expert system for medical support of crew members during the mission?
John, you want to?
Well, I mean, you're absolutely right. I mean, you have no choice. You're going to have autonomous capabilities that basically give the crew the ability to do the things that they need to do, because you don't have real-time communication.
But have you some idea about structure and content of expert system?
Larry tested one in space.
And how use such system for real medical support?
Jeff, you were a space smart med systems guy. I mean, I think the technologies in it is evolving.
Mainly for Mars mission, it's very important to develop such system. And if we not begin this activity in time, we have no possibility to give some technical requirements for fulfilling such system for Mars mission, for Moon mission.
I think one of the things with smart medical systems is it starts with the type of technology we heard about yesterday, with devices that can give the individual crew member feedback on their performance. And then it begins to build on top of that capability so that you can envision a next generation of interactive software programs that will help a crew medical officer more accurately diagnose a clinical condition in space. There's a lot of work being done on very smart biomedical systems, portable sensors, nanosensors, and basically trying to take our current ambulatory monitoring system, which, going back to another millennium, was this big array of electrodes and electrodes here and these big monitors, and miniaturizing that into smaller portable devices to collect information. All of this then feeding information back to flight surgeons that can help in space.
Yeah, I agree. You're right, absolutely. But I think that medical solution about the possible consequences of impact of negative factors, solution concerned with some changing of plan missions. It's a very important system, must be solved and developed only by specialists, but not system. But how organize the activity of such system? How organize the information interaction changing between the specialists and other factors that must be involved in this system? It's very, very difficult and important problem. It must be developed during the special time with testing, for example, on board the ISS, and only after that recommended for using on the Moon and Mars missions. That's my opinion.
Mm-hmm. Yeah, Dave.
We tested some expert systems on SLS-2 that Dr. Young put together, and they showed great potential, and I think expert systems will be critical to semi-autonomous operations. Let me make an analogy of how they might operate. In a navigation system, we have, for example, a GPS sensor, and when you lose GPS signal, you might carry it inertially for a while, total autonomous. I would see the interaction between the ground system, the telemedicine system, with an expert system where you use the ground system to the degree possible, and then at times you'll be left to yourself or to carry you through the time delay. For example, then you'll have your expert systems more like your inertial system, your internal system, and you'd play those together.
One of the things at this weekend is we have an opportunity to identify critical areas. Yesterday, one of the key areas we were focusing on was radiation behavior. These types of technologies and capabilities must be developed. And I would challenge all of you to look at using the space station as an exploration-enabling research platform to do exactly this. The signal delays to the Moon and Mars are going to be critical, and the type of technology Dave was discussing are very, very important when you have that signal delay added into the overall system. Now, it's very fortuitous that Dave answered that question, because one of the other challenges that we have yet to talk about is in constructing the space station, we have now entered what we refer to as the wall of EVA. Never before in the history of human space exploration have the major spacefaring nations done so many spacewalks. Needless to say, in the context of doing these spacewalks, we've encountered a host of medical issues, some of which have been very surprising for us and some of which have been somewhat predictable. Probably one of the surprising areas is that for many, many years we developed research protocols and strategies to prevent decompression sickness. Everyone predicted we would see an episode of decompression sickness in space, and yet, to the best of my knowledge, we have never encountered decompression sickness in any spacewalking crew member on the Russian side, on the US side, or in any of the other international partners. So I think that's one area that the research protocol that was put in place did very, very well. But let's talk about another set of problems, and those problems focus on what we might call overuse orthopedic injuries. The design of the EMU, the current spacesuit that we're using on the US side, is quite a bit different than the design of the Orlan spacesuit, and the tasks that we're able to accomplish with the different spacesuits are complementary. Both suits complement each other in going out and doing spacewalks and helping to build the space station. But one of the challenges that we faced in the EVA branch at JSC was the increasing incidence of what we call rotator cuff tears, damage to shoulder muscles related to the design of the suit itself. And it turns out the position of the side-bearing joint, where the upper extremity attaches to the hard upper torso of the suit, was such that it limited the movement of your shoulder, and particularly when crew members were working and training upside down in the NBL, this was compressing the rotator cuff muscles, leading to overuse damage to the rotator cuff, and in some cases requiring surgical repair of the rotator cuff. A remarkable phenomenon when you consider the skill set of an experienced spacewalker, taking them out of training for a period of time to get surgery on their shoulder. There are other areas, though, and I think, Dave, the question that I have for you, and with your experience in EVA, and as EVA branch chief, is balancing the design and the current capabilities we have in the suit with the potential for overuse injuries and things. What role do you see medical factors playing in all this? How should we incorporate our knowledge of the potential for orthopedic injuries into suit design? Particularly, one of the challenges we faced recently is the hole in the glove scenario, with a solution as the implementation of the overglove, and yet we predicted that we would probably see an increase in forearm overuse injuries. And lo and behold, our prediction has come true, and we're seeing an increase in lateral epicondylitis related to the use of overgloves. So I'd just like you to comment on EVA and the challenges that we face in developing suits and the capabilities for crew members to work in this unique environment.
A few quick comments. That's a huge topic. I want to go back to the decompression.
In 2 minutes, please.
Yeah, we'll do it in 30 seconds, maybe.
Kidding.
The decompression thing, we have a flight rule that says even if you get minor decompression, such as symptoms such as tingling skin, and it resolves upon repressurization, which is a confirmatory clue that it was a decompression symptom, that you won't be able to be exposed to another decompression event of any kind for 72 hours. So there you have it. Little tingling skin while you're out EVA, could be from any cause, happens to get better during repress, and you've just blown a whole shuttle mission. Because you cannot do it. You can't even go into the camp out to prepare for the next EVA that way, with the way we have it set up. So I personally think that who would in their right mind report such a symptom? And so when you say we've never had a decompression event, I think we've made sure that they don't get reported. Now, because everyone knows those rules. Second of all, now where were we on the other question? The suit itself. The suit is a biomechanical system, and it is part of you, and it's very hard to work and move in. And right now we are operating at negative margin. This suit was designed, the EMU, to emergency close the payload bay doors and retract the KU band antenna in the early 80s and late 70s. And we're now using it when was it? Help me out.
No, it was designed because the people wanted to build a hard upper torso, not because we needed it.
We didn't even need it for shuttle? In any case, it was designed in that time period, late 70s and 80s, and without specific consideration of what it would need to do to build a space station. And then we had to modify it to the planar hard upper torso from the old pivoted style, which limited the scapular motion and led to this impingement syndrome that David actually figured out for our branch how it worked. But the point is that we're exceeding the operating envelope of this system, and we see injuries as a result. And we are at the end of a 6-hour EVA, the condition people are in is not where you want them to handle the kind of emergencies that can come up, aiding your partner. I could go on and on, but trust me, we're way beyond the operating envelope of this. We're using it beyond its true design envelope. And you do this with airplanes, and you do this with every system. You get all you can out of it, and eventually you exceed it. And it's not worth the money to build a new one right now for the shuttle. You couldn't even do it in the time remaining, and there's all the issues of money that come into play.
Excellent. So as we go forward in that environment, the challenge is going to be taking the knowledge we know about the biomechanics of the suit and how to mitigate the injury and incorporating that into a new suit design for planetary exploration. Dave, are you confident that that process is taking place?
That's great. The Gernhardt and the large team he works with Judy's group and such, are really looking at weight and balance and weight distribution and expert systems which cross from operations to medical, because in a spacesuit it's a gray area between them, and one can become the other very quickly. high CO2, for example, and the myriad of other failures, pressures. So, yes, I really like what I'm seeing, but on the other hand, the CEV, or the exploration program, is marching along fast, and we have this readiness level, TRL, technical readiness level issue to deal with. And of course, it lowers the risk to take a high technical readiness level component or spacesuit, and this is directly contradicts innovation. And so there's a push, of course, to get hardware built as soon as possible and designed. And how do you do this and promote innovation? And this is the challenge to our managers, to partition that.
Vladimir, as we're looking to send an international group back to the moon and ultimately on to Mars, I was wondering what development is going on with the Orlan suit to transition the Orlan suit into a planetary exploration suit.
Позвольте воспользоваться еще раз традицией, вернуться на один вопрос позже, потому
I would like to go back to our tradition and maybe to go back to one question behind. We were talking about the psychological support and behavioral support, and I'd like to talk about it. This is a very significant issue. Of course, we do forget sometimes that in space we have regular people, humans, and they have their own intergroup dynamics, their issues, and there are some issues that they are carrying with them on board this station, and some of them that are created anew in this new environment. And therefore, we need to strike the right balance and how to find the appropriate position within the group, within the expedition, how to be successful in implementing the mission objectives, how to support yourself, how to express your opinion, how to manifest yourself as a specialist, and also how to avoid any problems or many problems that occur during a long duration mission. And naturally, the further away we are from the Earth, the more options there are for negative manifestations within the group dynamic, within the interaction with the vehicle, and of course, as closer we are to the Earth, then there is more interaction with the flight controllers on the ground and the more support we can provide. As you know, on board the ISS, a crew member, in real-time mode, can discuss all the issues with Mission Control Center. Sometimes they can yell at the flight controllers on the ground and they feel a little bit better. So this is the way to kind of let the steam out. But the further away you are from the Mission Control Center, the more difficult it is to do that. And therefore, the main problem, as I anticipate, that will occur in long-duration flights further away from the ground is the radiation. And these are very complex issues. They require overall review and assessment on an integrated basis. And therefore, we were talking, I don't remember, somebody from the astronauts mentioned that radioactive particles are washed out using the red wine. And as the medical community, of course, we try to avoid the usage of the wine for adaptogenic factors and whatnot, but at the same time, sometimes it helps to alleviate the psychological stress, and therefore the question, shall we legalize that as one of the resources, or are we going to hide our head in the sand and say that we do not have any right to use any alcohol or any wine for psychological support either? So that's a question. Now we're talking about the suit, EMU and Orlan suits. If we look at the design, these are different models. EMU is very user-friendly, it's a soft suit, it's easy, you can perform some delicate operations, dexterous operations. What is the disadvantage is ingressing into a suit, you have to be aided by another crew member. As for Orlan, it's like walking into your apartment. You open the door, you go in, you close the door, and you're inside. You're within your autonomous system, Orlan suit, and therefore advantages and disadvantages weighing in. So if we are talking about an international crew flying to the moon, and I hope it will be an international crew, we need to use some good systems that have been used and tested, both EMU and Orlan suits.
As to whether there are going to be any modifications for the spacesuits, of course, they will be needed, and we will have to strengthen the feet and the balancing of the suit. It was brought up yesterday as to whether the center of gravity needs to be placed in order to perform the tasks, as to whether it will be fixed or dynamic. I think it will be dynamic so that it would be possible to move it once we go up or down. And naturally, there is the question as to how we're flying there, whether we're flying straight from the Earth to the Moon, or whether we go through the additional method by using an orbital vehicle that orbits around the Moon, and that we would have to bring one or two modules that would land on the Moon, whether there's going to be one or two, and whether we are bringing the crew together or whether they are landing separately. And then if they are landing together, so then we find out who we are bringing down, whether we're leaving anyone in orbit, and then we need to ensure redundancy there. And so until we get a clear understanding of the scenario for the flight, we will have a number of different opportunities to get together and talk about it at the conferences like this one. I'd like to conclude with that.
Thanks very much. I think it's very important for us to identify these opportunities to get together and talk as we go forward developing these technologies. We're now planning to use the station as an exploration enabling research platform, and hopefully we will see humans back on the Moon by the 50th anniversary of Apollo. And doing that using new technologies is going to be very, very compelling, but we need to start doing this work now and get going and developing these capabilities. I'd like to transition at this point. And with your indulgence, I'd like to request that we go till 12 o'clock, if that's okay. It adds 15 minutes to our presentation. What I'd like to do is focus a little bit on a real-world scenario that we are given when we prepare to go into space. As crew members, we participate in something called Joint Integrated Sims. And these are sims that involve the mission control, both in Moscow, here in Houston, getting crew members ready to go train and fly in space. When I first flew in space, in another millennium, we didn't use clinical cases in these simulation exercises. All of these simulation exercises focused on off-nominal systems failures and contingencies that we would get into in the shuttle program. And it's only recently, over the last 3 to 4 years, that we've started to add medical scenarios into these integrated sims. The case that I would like to present to our committee and to our audience to consider is one of a crew member on board the International Space Station that's been on the International Space Station for approximately 2 months. And this is a U.S. crew member who's on the station, went through all the appropriate screening, has no past medical issues that would impact their ability to fly a long-duration mission, has been doing very well up until this point on their long-duration mission, has participated in a couple of spacewalks, stage spacewalks, and done very, very well. Has also participated in an exercise program while they were on board the station. But turns out that they've noticed some challenges with their EVAs and their exercises, and they're getting the old aches and pains that go along with this. So they've been using non-steroidal anti-inflammatories, Motrin, to take care of their aches and pains. The situation that was given to primarily myself when I was training for STS-118 was the following. I'm outside doing a spacewalk with Rick Mastracchio. Inside, we have Tracy Caldwell, our IV crew member over on the shuttle, taking care of running the choreography for the spacewalk. And on the space station, one of the crew members ends up with a simulated medical condition, and they were complaining that they felt lightheaded and dizzy. So the shuttle, of course, is docked. So we have a total of 10 crew members on board at this point. We have one crew medical officer on board the shuttle, and we have another crew medical officer on the station crew. And they go together to talk to the station crew member that's feeling lightheaded and dizzy. They set up a primary medical conference, and the information that they have so far is relatively rudimentary, that the person's been taking a lot of Motrin, they feel weak, and they feel dizzy. The crew members found the ISS medical kit, they deployed it, they took out the blood pressure cuff, and they found that the individual has a blood pressure of 70 systolic and a heart rate of 120. And they're now talking to flight surgeons. We have many flight surgeons on the panel, and I don't want to drag this on too much, but very quickly, what would the team like to do from a flight surgeon perspective on the ground? What would you like the folks to do on orbit? Anybody want to hazard a guess? Smith, you're leaping to the microphone.
Well, first of all, who let her take all that Motrin?
Ну, правильно, американский врач экипажа, член экипажа тоже.
So here's the U.S. flight surgeon, and we have the
I'd want a history.
U.S. crew member.
What's going on?
Okay, so we can get more medical information, sure. And at the same time, they're wondering if they can go ahead, start some IVs, and get a little oxygen on the person and things. So they do that.
Are they having abdominal pain? Is that?
No abdominal pain.
Yeah.
No abdominal pain. So we're getting more history, we're asking more questions, and we're getting going, doing a little resuscitation. We have 2 crew medical officers, and we want to get a sense of how long it's going to take to start an IV in space. Now, Jay, you and I have done this a number of times. And when we were trained, people used to tell us they would 10 to 15 minutes max. Well, by the time you go and you get the ISS medical kit, and you get it out, and you spread it out, and you Velcro it to the wall, and then you dig through the kit to find whatever angiocath you want, and then you position the individual and things. It's roughly about 20 minutes or so before the...
No way. Never get it in there.
We're having a dissenting vote. Okay, let's say a half an hour, somewhere, beyond that. So we're looking at roughly, 30 minutes or more to find the kit, get the IV out, put a tourniquet on, establish IV access. At the same time, the crew's wondering, should we go ahead and terminate the EVA? Because you've got a crew medical officer outside, and you're kind of thinking ahead here. So the decision is made, let's terminate the EVA. So Rick and I are brought in. We enter the repress cycle, which of course doesn't happen right away. So we now have a delay until Rick and I are out of our spacesuits. And we add another, what do you think, Dave?
To get out of the suit?
Yeah.
From ingress?
Right. The total, I'm outside, I'm coming back in the air, 45 minutes. So now we're an hour, 15 minutes into this. And I'm in my LCVG approaching the patient. The information that I was given at this point, where we have one single 16-gauge IV that was inserted successfully by the 2 crew medical officers that were inside, and they've given a total of 2.5 liters of normal saline to the patient. The patient's blood pressure went from a 70 systolic value up to the dizzying heights of 85 systolic. The question becomes, how much normal saline do we actually have on the space station? I'm a shuttle crew member. I know I've got 1.5 liters. How much do you guys have on the station?
12 liters and 500 cc's
okay.
of D5.
So we have 12.5 liters of fluid. We've already given 2 liters, and the patient has minimally responded. So the question then becomes to our colleagues on the ground, what do we want to do? Are we going to stay and try and fight this battle, or are we coming home? So the decision that was made in the Joint Integrated SIM was, we're coming home. We're going to do an emergency undocking, contingency deorbit prep, come back and land at a PLS. And our PLS, roughly, we're about 6-7 hours away from being able to land. So the question is, looking at the volume of fluid that you have, 1.5 liters on the shuttle, you got 12.5 liters on the station, how much do you guys want to leave for the station crew that are going to be remaining once we undock?
How was the diagnosis of an upper GI confirmed?
Yeah.
It was never.
Never. Okay, well, I think that's the first thing.
Right.
Yeah, you want to.
Right now, all we're doing is resuscitating. Right? I mean, you guys are thinking what everybody's thinking.
This guy's not unconscious yet, is he?
Well, he's dizzy and he's lightheaded and things, but he doesn't know anything. All he knows is he's been taking Motrin. So the bottom line...
Being in space and you have a blood pressure of that, you've lost a huge amount of fluids.
Right.
You've got to find it somewhere.
So either your spleen's gone, or you've had a massive bleed, So you should be able to know that, and he should have probably had other symptoms before he would have manifested that low blood pressure.
Yeah. So if you really, prod this person and kind of pull it out of them, they've had some gastric irritation for the last little while, and if you ask them about when was their last bowel movement, they can't really remember. And, when you're using the WCS, things are kind of floating, so you're not really looking. So they have no idea as to whether or not they've had dark, tarry stools or anything like that. Basically, very bad history. It's very typical of space medicine. Very bad history, minimal physical exam, not too much in the way of helpful signs, but we have a profoundly hypotensive patient in the absence of anything other than a suspicion that it possibly could be bleeding into the gut. You can't see the blood, it's got to be somewhere, probably in the gut. So right now we are resuscitating. That's all we're doing. We don't have a clue what we're actually treating for sure. We have a suspicion, but we're resuscitating. And I'm evolving this as it was evolving during our GIS. And needless to say, there's lots of learning points here. But the decision was made without really a confirming diagnosis that based on the physiologic parameters, we're going to undock, deorbit.
Really?
Yep.
Wow.
Yeah.
Ouch.
So they made a $500 million decision without having confirmation whether or not this is something that they could actually treat and save versus, okay.
Well, the question is in terms of treating on orbit and saving on orbit. So, we're an hour and a half into this. They've had a couple liters of crystalloid. The blood pressure is marginally responding. And the decision was made, yes, let's proceed, and we'll go ahead and undock. And this was the real decision that was made at the time.
Sure he wasn't taking Valium instead of Motrin?
Did they put him in the ACEs to come home?
That's another story. So let's work with the assumption, okay, and you can see the challenges in making a real-time diagnosis. Smith is quite accurate that there are other things that could be causing this. All right. The but in all this, though, is these are the real-time dilemmas of space medicine. Okay. Do you undock? Do you come home? Do you stand and fight? And at what point do you make this decision? So it turns out the diagnosis that they wanted us to be treating was an upper GI bleed. That was the suspicion. So now the issues that we get into are as we're undocking from the station, we want to maintain some degree of treatment capability. What do? Do we take material from the station's kit with us? Do we just use the shuttle material alone? And the decision that was made during the GIS was to take half of the station's supplies. They have 12 liters of volume resuscitation. We took 6 of it to come with us. And we have 1.5 liters left. So we have a total of 7.5 liters. We close the hatch. We go through the undocking scenario. We go through getting ready for deorbit, which, remember now, we have an extra crew member, and you have the CMO taking care of this extra crew member. So you're one crew member short from a shuttle perspective, and you're taking care of this individual. And the question arises, what do you do with the CMO? What do you do with the patient? Do you put them in suits? Do you even have a suit for the individual? Any thoughts on that? Dave?
At great risk of the ire of people, this is just a personal view. I'd be against the suits maybe for everybody. When you're that busy, and it's like a kelp bed inside the vehicle, swimming through suits, you make mistakes, and I think you have much more chance of a big accident that could take everybody out. And if you just leave the suit stowed and do a short sleeve entry, when things are confusing, you're better off, I think. That's not probably what the agency would think.
We won't tell Marcia, Dave.
I'm going to go back a step. I can test the emergency or urgent undocking, which is very risky. And considering that we have 3 primary landing sites in the U.S., is that where you're going, or are you going to do a site that's overseas somewhere? Because you're going to have to go through the reentry G-forces, the whole thing. And again, I'm a kind of person that says, are you putting the other crew at risk to save one person? And you are. You're putting everybody at risk. So I would contest the emergency undocking and deorbit and say, let's stabilize and fight and see what happens. But that's just me.
No, that's a good... I don't want to say that what was done in the sim was the correct response. I think what's really interesting about this, though, is the need for discussion. Discussion also takes time. The clock is ticking. and physiologically things may or may not progress. So it stresses all of us in the system to start thinking, what is the best outcome in this situation? Is it best to undock and get back on the ground, or is it best to stay docked and deliver whatever health care we can, stabilize and resuscitate, and we're going through consumables? And the reason why I picked this case is it's highly controversial. You know, you could debate either perspective. So they are going to a site in the States. There's no question about that. They're chugging along, and we were going through this real time in the shuttle simulator, and we noticed right away there was a huge flail in terms of getting the middeck and the flight deck set up. The priority, of course, is set up the flight deck so that the flight crew, the pilot, the commander, the MS-2, and the MS-1, or your flight engineer behind the pilot, can actually do their job. That's the priority. So we got that set up, but the middeck was in a state of chaos as we're trying to hook up oxygen to the overhead to give to the patient through their mask, to continue the IV solutions running, to get the 3 seats set up on the middeck. As a crew medical officer, I actually suited myself, but we did not suit the patient, and I did not put my gloves on or put my helmet on. And the way this scenario proceeded was that basically we ended up running out of fluids at around 200,000 feet. And the very sad situation was a progressive physiologic decline in the patient's state, such that the blood pressure was not palpable at about 100,000 feet.
Right when G's come on.
Yeah, and by the time we landed, the patient was in extremis, shall we say. So it illustrates a number of very fundamental questions. And the reason why I throw this case out is because we sim these things. We talk about them afterwards. We need to train these things, and it illustrates all the challenges we face in space medicine. The first situation, as Smith and John rightly pointed out, is what is the diagnosis? How do we confirm that diagnosis? And are we doing the right thing based on the diagnosis and a risk mitigation strategy? So even if we knew right away that we had the right diagnosis, the challenge is understanding the risk of staying and treating versus the risk of undocking and landing. And that has to be made real time in a very short time period, and it's one of these things that I think is very, very important in going through and continuing to introduce these medical problems as we're training to prepare members to come back. Another challenge that we face is the limited consumables. We have 12.5 liters of saline in space on board the International Space Station. In veterinary medicine, we reconstitute IV solutions. So the volume and the weight is a lot less. Smaller containers, and you reconstitute it whenever you need it. We need to be looking at novel capabilities like this to be able to bring them to space medicine. You know, we were talking about giving fluid starting large bore IVs. We're giving a fluid, but we're not giving anything that will carry oxygen to replenish the blood that has been lost. We don't have any artificial blood replacement. The military is very interested in developing this for combat scenarios. We have a similar shared interest in developing this capability for space. And one of the most striking things that I found for me as a crew medical officer in this scenario is trying to grope with what is the right thing to do. And we're talking back and forth with the flight surgeon. All this is evolving real time. The patient is going down the tubes, is what we call clinically. They're not doing well. And we're going through all of our limited consumables. We're fighting this battle, and we're wondering what the outcome is. And it gets back to something that Walt raised earlier. And at some point in time, we probably have to sit back and say, we cannot develop and maintain the clinical capability to treat everything and do it successfully in all these medical scenarios. But as we go down the road, we need to use cases like this and the controversy that a case like this generates to think about what are the new diagnostic modalities. How would we confirm the diagnosis in this case? Are we going to take an NG tube, ram it down and suck out blood and go, up, it's an upper GI bleed? How do we do this in this environment? What new technologies, what new modalities do we have to work on? The NSBRI is working very hard in looking at non-traditional uses of diagnostic imaging, such as ultrasound, using ultrasound to help crew medical officers be able to image devices. Also on STS-118, I did have an opportunity to use the shuttle medical kit. I did it both times that I was in space. And I found that I actually ran out of one medication on the shuttle medical kit during the mission. I had to borrow medications from the ISS medical kit. Fortunately, we were delivering a new ISS medical kit to the station, so I borrowed the medication from the ISS medical kit that was coming home. So I throw out this clinical case to raise the question, as we're going down the road in the future, what research are we doing in actual clinical skills in space medicine, delivering and changing the practice of space medicine so that we can then develop the medical capabilities we need to go back to the moon and on to Mars. And Rick could...
Well, I was just going to mention that scenario that's very similar to a medical scenario Hammy ran back in 2004, an MI in space.
Right.
And what was very interesting about that sim, along the lines of capabilities, was about 5 minutes into the sim, according to the ACLS protocol, the crew member of the CMO was instructed to start two large bore IVs and run with it. And within a couple of minutes, she had come back and said, "Okay, I got him in." And I thought to myself, there's no way that had happened. And after talking to Scott Pierzynski and some of the other folks who've actually started IVs in space, they said exactly what you guys did. And that started the whole idea that we really should use IO in space. So we've actually studied a lot of different of the off-the-counter or off-the-shelf products, look to the military, and that's one of the things we're pushing for, is to have interosseous access device in space as an adjunct to conventional IV. We just did some C9 studies to demonstrate that clinicians and non-clinicians can get them inserted into simulated bone just as quickly. We've addressed most of the major concerns regarding IO, and in the long and short is it gives a non-clinician the opportunity to start or get immediate vascular access very quickly with limited training, and takes something that would be very time consuming from the crew members' standpoint, get that out of the way, get it off their plate. What's the driver for that? Are there that many conditions that require immediate vascular access? Well, there are a few that we actually, based on a study that the flight students have done about concerns for medical conditions in space, that there would be some justification for doing that and pursuing it. We're trying to do reality checks here and think about what we would really expect to happen. So that's one technology that we're pushing to get on our kits and to really move forward. Just FYI.
Jeannie, did you have a comment? Okay. Oh, sorry.
Yeah, hi. Yeah, that's actually I found to be a very interesting scenario, because we are developing a non-invasive sensor that looks at tissue perfusion. I think it was the sensor Dr. Sutton talked about, which measures blood and tissue chemistry. And right now we're developing it as an in-suit sensor for calculating metabolic rate during EVA, but it has a multiple applications, and in particular the application we're working on for the Army is as a very early indicator of tissue perfusion. So and we have demonstrated on humans that in your scenario we would have known long before the blood pressure fell that this person was at risk, and you probably would have been able to make that decision if you needed to evacuate before you would have run out of fluid.
Excellent. Yeah, up in the back. Kevin.
Thank you. I just want to come back to a point that's made earlier about there are some things that you're going to have to just say, you can't get out of this situation in space. I mean, I'm a critical care physician in the UK. I have the misfortune of having been on for 2 of the bombings recently in London, 7th of July, nail bomb in 1999, and a couple of train crashes. So you should all feel a little bit more nervous sitting in the same room as me. But our protocols, and I was pre-hospital at Soho, our protocols are that you triage people, and you triage people at an expectant triage category if they have arrested or they look like they're about to arrest, because the greater good for the greatest number. And yet actually in all of those major incidents there were prime examples of all of our teams resuscitating people with massive use of resource, even though really they should have been triaging them as expectant. And we've been over this quite a lot. I work with the Department of Health at home. The Israelis, who've had 103 suicide bombings in the Intifada, say that they've never been able to do that. They've never, ever been able to triage people as expectant in their experience, because in their cases, it's very often members of staff who they were looking after. And so I completely agree that medically, you're looking at futility very often in these cases. But operationally, to train and to have a protocol that says, we will not treat here, I think you might find very difficult, and I was wondering what your points of view were on that.
I didn't hear anyone say to do that. What I think I heard was, maybe we heard different, was you try and aren't going to be able to get there. Even if you don't have the full resource, you'll do what you can to the end.
Well, that's my contention, is that you stand and fight because you're putting the other crew at risk. An emergency undocking? I mean, come on, guys. You know what that would do.
Yeah.
Where's the flight director and commander saying, wait a minute, I mean, maybe some of the astronauts can chime in here, but I'm like, the medical guys should handle it on orbit for the time they can, but you can't put other people at risk without this being well thought out. And time will tell. Time is a diagnostic tool we very rarely consider, but time in this situation, I think, would have given you the answer. The other thing is we have high-frequency focused ultrasound as a countermeasure assessment and countermeasure tool that downstream, I think, would have been something that would have been able to consider in this.
Probably won't work for GI bleeding.
Yeah.
Diagnose it or treat it?
Well, you can
You can actually treat.
As a general surgeon and a trauma surgeon. And the other thing I'd say, if you think about living off the land and medical MacGyverism, if you have a crew member who's got the same blood type, you could potentially give whole blood, which would be the best way to stop the bleeding, and that would be something to consider in the future.
We don't have that capability though to do that, but
As a crew.
yeah, but that's a good thought. Yeah.
Yeah. Walt, we get a mic over to.
Point. We know everyone's types.
Yeah.
Yep.
Make sure no.
I found your sim to be terribly interesting to me, Dave, but it also brings up the fact that what I mentioned earlier is that whatever you do medically is going to cascade and have a lot of sometimes even unplanned kind of reactions. I agree with Dr. Clark up there. The measure of success, the doctor is going to measure success on a different scale. The crew, I guess I can't speak for all crews, but I can speak for our crew. They're measuring it by mission success. It's the entire mission that's important. And I have to tell you, there are some circumstances when other aspects, other measures of missions of success are going to be expendable. And it's back to that same thing I said. You've got to expect losses, and you've got to be very careful that you don't end up doing things. I'm not sure how risky and unscheduled undocking is, but we shouldn't ignore the investment in both human resources, monetary investment, and all those things on the mission itself. We should only be flying missions like that have a terribly valuable return, and you ought to be very hesitant about ending the mission before it's been successful, because the mission could have been successful even with the death of that fictitious crewman.
Excellent. Thank you. Yeah. Cool.
I will say the obvious. Why don't you put the same simulation?
She's good. Go, girl.
I'm here. Just very obvious comment. So why don't you put that simulation in the context of lunar exploration for the current architecture, or even for Mars mission scenario. So for present architecture, if you have the same case, how much time you have for return to Earth? You have 2 days, 3 days?
Actually, right now, if we land at Shackleton Crater, the South Pole, it's 6.5 days, up to 9 days. And that brings up something that Jeff... From the moon. If we're launching from Shackleton Crater, it's 6.5 to 9 days, and that brings up something that Jeff Jones and I dealt with. They wanted to know if immediate return capability was something that MedOps really wanted, and when we considered that nominally it would take 6.5 days to get back, what they were driving at, it would save them 5,000 pounds of prop to do an immediate return as opposed to just waiting for orbital phase changes and to get back to Earth. And we gave up immediate return because it didn't buy medical anything to do that, and it saved them supposedly 5,000 pounds of propellant. Unfortunately, we didn't get that back in medical capabilities, but we told them that really, if you expect us to do that, then we need more capability, that we didn't initially have, and that was kind of the trade-off that we made. I haven't seen any fruits of that compromise, but
yeah, Jeannie.
Yeah, well, the decision may have to be taken out of the flight surgeon's hands because it's contrary to the Hippocratic Oath to make some of these decisions. So I go back to what Walt said a couple hours ago, is there needs to be a list of conditions, and we've learned through the development of the patient condition database that there are certain things that happen and you'll expend all your resources just like that. And so on a trip to Mars, you can't afford to do that. when it will probably end in a negative outcome anyway. So there needs to be a list of those conditions that you cannot treat, and the decision is taken out of your hands. So a flight director says, this is on your list. We know the outcome is potentially 90% potentially no good, and you'll use 90% of your resources to try to change the outcome, even though it's not possible. So I think that list needs to be developed.
I'm going to take this to a place that maybe you don't want to go. You've talked about the impact on the patient. You've talked about the impact on the crew. You've talked about the impact on the ongoing mission of the shuttle, of the station that will continue. What about the impact on the public if a decision is made one way or the other? Now, I appreciate all of your considerations that you're dealing with many, many difficult trade-offs. But the responsibility is also to the public.
Right.
That's what
Right. You let them know that the ISS has a, 1 in 14 chance of having a major orbital rehit over the life of the station? And
But the day it happens, things are different, because that's your day. And so enter politics and public in this decision, and it sure looks better if this person died during a fight to save him, than died while you decided to let him die. And all the critics get their handle to throw you down with. And so how responsive are we? It's classic to the critics, critical minority.
I'd like to finish, and I know we have a lot of questions, but I'd like to finish off by wrapping this up so we can go to lunch and continue the discussion at lunch. It was great. But as we go forward and we look at this, we could keep the discussion going all day on this, because these are critical questions that need to be answered. And the advantage is that we're starting to answer. The really talented group of people that you see at the table in front of you, they're the ones who are bringing these complex problems into the simulation environment so that the dialogue can happen. In the absence of dialogue, we're not going to be able to get to where we need to be able to get. I think what's truly remarkable about this is if we sit back, and I'd like you really to consider this at lunchtime, and we go back to my story in the beginning, looking down at the planet Earth, the cradle of humanity, leaving Earth to go back to the moon and on to Mars. For the first time in the history of the human species, we are going to have humans living on another planetary body 24/7, 365 days a year, like we do on the space station. This represents that next phase of humans going elsewhere in the solar system. This phase is going to be technologically enabled. We will rely on technologies to keep humans alive in these unique environments. We undoubtedly are going to lose crew members participating in the exploration of space. It will happen because it happened in the history of the human species. The lessons for the future are written in the past. If we look at what happened in the history of exploration, discovering the Americas, discovering the Antarctic and the Arctic, summiting Mount Everest, that history has had the tragic loss of human life associated with it. So as we go forward in space, I think we need to accept the wisdom that Walt brings in talking about the fact that we've got to look at the list of medical conditions, what we can do, what we can't do, trying to optimize our ability to succeed, and using the space station starting today as an environment to help us learn and deal with these issues. At the same time, yesterday we focused on very important physiological issues that raise the question about the long-term health care of astronauts. The health care to astronauts does not stop the day you land. We have a rehabilitation phase for long-duration crew members that lasts months. And I would submit that the team in flight medicine here at JSC and the team over in Russia is concerned with the long-term health of astronauts and cosmonauts. And we need to be followed right through our 60s, 70s, 80s until the day we die. And the information gleaned from that helps us to understand the biological effects of flying humans in space. And perhaps we should consider making sure that we have the capability of delivering the appropriate health care to our aging astronaut population once they leave the Corps, whether they develop leukemia or whether they remain healthy, that we're involved in maintaining their health and preserving their capability because of the commitment that they made in going forward and exploring space on the behalf of the human species. Thanks very much to the panel. Great job, everyone. Really appreciate it.